I'm kind of crooked. Hello, hello, my friend. Stay. Stay. Hello, everybody. Hold on a sec. I'm trying to do something different today. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is time for another IC support group meeting. Woo! Lots and lots and lots of things to talk about today. But let me get this stream up and running. Oh, Facebook is not running. Hold on a sec. Hello, hello. Okay. Excellent. It looks like we're live on Facebook. And it looks like we are live on YouTube. Hello, hello, hello. It is a glorious day here in California. Beautiful day. I hope you're having a wonderful day yourself. Beautiful blue sky. It's going to be pretty warm today. I was out early. And I love Sundays because I get to come and talk to you. And so this is a support group meeting for men and women struggling with pelvic pain. That can be bladder pain, that can be pelvic floor pain, that can be prostate pain, you name it, we'll talk about it. I welcome any and all questions you have. Ideally, this is a meeting for patients and family members and their friends, for people who just do not understand why you have somebody who has to stop and use the bathroom all the time. And like, do you believe them? No, a lot of people don't. It's like, come on, Jill, you just paid 30 minutes ago. Why would you need to stop and go to the bathroom again? Well, that's what happens sometimes when you have a pelvic injury. Of course, that can happen with a UTI, but it also happens after injuries. It happens after traumas. It can happen for a lot of different reasons. But put yourself in the place of the patient. Number one, they feel like they've got a bladder infection all the time, and yet the cultures are negative. Number two, driving in a car hurts like hell. Number three, they have every bathroom in your community memorized. Number four, they don't want to go on trips because they're going to have to stop and use the bathroom and annoy everybody. And before you know it, you've got somebody who is isolated and homebound, people that people forget. It's like, well, aren't we going to invite Jill? No, we're not going to invite Jill because she probably can't come anyway. Or if she comes, she's going to ruin it because she's going to have to go to the bathroom all the time. At least that's how I felt. And our job now is to make sure that you know this is real, that this is treatable, that you are not alone, and that there is, in fact, hope. There is tremendous hope here. We know what this is now. It's exciting. We are so much better off today than we were 20, 30 years ago. And, you know, for patients who have struggled with interstitial cystitis for many, many years, you know, they stopped going to the doctor 15 years ago. The doctor was too depressing. The doctor didn't have any suggestions for them and recommendations for them. So they just stopped. Many of them have just been taking Elmeron for decades and not necessarily getting better. Those are the patients I want to find. Because guess what? You might not have a bladder disease. You might not. You might have an injury. You might have pelvic congestion syndrome. You might have a fibroid tumor pushing on your bladder. Lots of different things can cause these symptoms. I don't want you sitting at home assuming that your life is over. It is not. Hello, Boria. It's nice to see you, hon. Hope you're doing well. It's always interesting trying, you know, back when we had a lot of real in-person support groups, which of course COVID destroyed, they all took the summer off. Of course they did. They took the summer off because everybody was out living their lives. And that same is true with online support. I mean, and so a lot of people watch these meetings afterwards, and I like that. And so if you're one of those people who is listening sometime in the next week or two, welcome. I hope you don't feel like you have to come to a meeting. I want you to spend your Sundays with your families and your friends, not necessarily coming here. But if you do come here, you're welcome. If you're having a flare, you're welcome. If you need support, you're welcome. Absolutely welcome. Now, it's been a very, very busy weekend for me. I was absolutely swamped yesterday, and I couldn't do a lot of things that I wanted to do because we have something very exciting that's happened. We have new guidelines. We have new guidelines. 2 sets of new guidelines, and we are going to go over these, and this is why I have a whiteboard behind me, because we're going to do a little just instruction, for lack of a better term. But before we go there, I want to show you something else that we've been working on, and that is we now have the new covers for our books. IC 101, the diet guide. I haven't changed it on the website yet. I'll be doing that tomorrow. And our flare guide, that's me. And our book, IC 101. And I also will be updating our book this fall for sure, because we have lots of new information. I just have to have the time to do it. Lots and lots and lots of time. So I welcome any and all questions. I will be here as long as you have questions. Sometimes our meetings go 5 hours. Sometimes they go 2 hours. Sometimes they're less. Sometimes it's more. I am here at your pleasure. And when we're done, we all want to go and just enjoy the rest of our Sunday. So let us. Oh, here. Oops, drop the microphone. Okay. So before I get into the nitty gritty of these fascinating it's a new global standard for IC care. I want to. Okay. So we have new guidelines from France. Now here us in America, we don't necessarily know what's happening over in other countries. I'm going to tell you right now that there's a lot of really good things happening for IC in Europe. There always has been. These French guidelines, along with the other one I'm going to talk about, which are the new European Society, the International Society for the Study of Bladder Pain Syndrome, I'm going to go over their guidelines too. So, and just I have to have my reading glasses on, so just bear with me here a moment. Little bit of history, just for fun. Just for fun, okay? I mean, it's a weird sense of fun, but it's my sense of fun. So, question number 1 is, when was interstitial cystitis first discovered? When was it documented? Any guesses out there? Any guesses out there? So, to give you the clue here, okay. In 1808, 1808, let's see, a doctor named Philip Singh Physic, a surgeon from Philadelphia, described a painful bladder condition with an ulcer on the bladder neck. I know we know Hunner's ulcers are a big part of IC, right? Okay. There you go, 1808. In 1876, Dr. Samuel LaGrosse was the first to use the name interstitial cystitis. Okay, and so that's like, a significant moment in the IC world. But the reason why he called it interstitial cystitis is because they thought at that time that it affected all the layers in the bladder. It turns out it doesn't. And we know now that the name interstitial cystitis is certainly not the right name, but it's what we're kind of stuck with. Okay. In 1907, Dr. Nietzsche, the inventor of the modern cystoscope, described the symptoms of IC combining frequency pain and bladder ulcers. Okay, so when they first looked in the bladder, they saw ulcers. Now here's something I didn't know. This is fascinating. Had no clue. In 1912, like 110 years ago, Dr. Howard Kelly was the first to describe patients who flared after eating foods. And he said, foods such as tomatoes, fruits, and acidic substances should be avoided when the patient notices they worsen their condition. Guys, like I thought that was discovered in the 60s. Like I thought I had read all the important historical documents. Turned out I hadn't. So we owe our diet back to a guy named Dr. Howard Kelly, a gynecologist from 1912. Fascinating. Okay. And then we have a name everybody should know, Hunner, Dr. Guy Hunner. So he was the one who was the first to really use the cystoscope to describe these ulcers in depth. Okay, that's why they're called Hunners. He called them ulcers, but we know that that's wrong. We can now call them Hunner's lesions. And then in 1949, here's the issue. We know a lot of patients don't have lesions. They don't. And it was back just after World War II that they started talking about patients with urinary symptoms, urinary pain who didn't have lesions. Of course, we now know that the majority of patients don't have lesions. But still, it's important. And interestingly, he was like the first to say, you know what? There are different patient groups. There are patients with lesions and patients without. It's like, hello, hi, gay, hello, phenotyping. So like they were on it 70 years ago. Fascinating stuff. Okay. So because they recognized that the name interstitial cystitis is inaccurate, back in 1951, another doctor said it should be painful bladder syndrome. Because urethral pain is called urethral pain syndrome. Vulvodynia is called vulvar pain syndrome. So shouldn't a painful bladder be called bladder pain syndrome or painful bladder syndrome? And the answer, of course, is yes. Okay, in 1978, Dr. Magnus Fall, one of the critical foundational European researchers for IC, said that Hunner's lesion patients are very different from other patients, different groups. Okay, we knew that. Okay, there's more. Let's see. Hold on a sec. I don't need to go over all these interesting things. When the European Society got together, which is now the International Society for the Study of Bladder Pain Syndrome, they were the first to really, they came to the United States and they said, guys, you got to stop calling this interstitial cystitis. This really isn't interstitial cystitis. This is bladder pain syndrome or painful bladder syndrome. And of course, they're right. But our entire health infrastructure is built around the name, which is why we call it IC/BPS. Okay. And so they made some distinctions. What they said, okay, basically, if you're going to keep using the name interstitial cystitis, only use it for patients with Hunner's lesions. Or like IC/Hunner's lesion disease. And for patients without lesions, let's call them bladder pain syndrome. And that's now kind of standard around the world, is that most people call this bladder pain syndrome, except here in the United States. And in Asia and Japan, they actually call it hypersensitive bladder syndrome. Which is interesting. Okay, let me see what else is here. Okay, so let us talk about groups, because this is where we all have a lot of work we have to do to make sure everybody understands kind of where we're putting IC. So I'm going to try this. It might not work, but let's just see. Okay. So we're going to talk about the different groups and kind of break it up a little bit. So there is a big group that we're going to call pelvic pain syndrome. Okay, so pelvic pain syndrome. Okay, so anybody who's got pain in the pelvis, there are a bunch of things that, we can't just say, it's a bladder issue, or we can't just say that it's a bowel issue. There's a lot of different conditions that can affect the pelvis. And I'm going to go through that in a moment. So, so for example, irritable bowel syndrome. So look, we can make a group here, IBS, right? That's a pelvic pain syndrome. We can make a group here, endo, right? Or we can make a group here, vulvar or prostate. Okay, so you get my drift, right? That inside the pelvic pain world, there are subgroups. Okay, so obviously the subgroup that we're dealing with is going to be, oh, you know what? I need to put one more in here. Okay. Okay. So pelvic floor injuries, pelvic floor dysfunction is clearly a pelvic pain syndrome, right? And then, of course, we have bladder, right? Pain syndromes. Okay. Emphasis on plural, syndromes. Okay. So now that we understand pelvic pain in its totality, that there are a lot of things, prostate, there can be a prostate in there. There's just a lot of things that can be a pelvic pain syndrome, like fibroid tumors, things like that. So let's go to what we're thinking about, and that is bladder pain. So here we are in Okay, so now we're in the bladder pain syndrome patient group. But we're not all the same, right? We know that we are very different as patients, because some patients have Hunner's lesions, right? Now, in much of the world, this is the group that's called interstitial cystitis. Or they call it Hunner's lesion disease. So these patients have visible wounds on their bladder. This is about 5 to 10% of the patient population. So when you go into a group online, there are going to be people who have lesions and a lot of people who don't have lesions. And you can see that it's apples and oranges and bananas. Their cases are not necessarily going to be similar. And so let me hold this up straight from the guideline. There you go. Bladder pain syndrome, interstitial cystitis. So the patients with bladder pain syndrome, they're going to have frequency, urgency, pressure, pain, particularly as their bladder fills. The most important symptom that helps us identify the bladder as the source of the problem is pain as the bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. And once you pee, you feel better. That points directly to the bladder wall. So patients who don't have that, the guidelines are really clear. If a patient doesn't have pain as the bladder fills, we need to look at other things. So, hold on a second. I'm doing my best here, guys. Hold on a second. So, the first really cool thing, and actually, I can actually go back to that the European guidelines talk about are all the conditions that have to be ruled out. And okay, so here you've got a patient who's got pelvic pain, urinary symptoms. Let's not assume that it's an incurable bladder disease. There are a lot of other conditions that can cause these symptoms. And for the first time, there is a really comprehensive list of all the things that mimic IC. Because listen, if you've been doing bladder therapies for years and you're not getting better, we need to figure out why. Because maybe it's not what you think it is. Maybe it's something else. So they're really putting the burden on the doctor to make sure that they have ruled out any other condition that can cause these symptoms. And the Europeans are very clear. They want a cystoscopy done as part of the diagnostic workup. They want a doctor to look in your bladder, because if you got lesions, they need to treat the lesions. And if you don't have lesions, then we're going to move on to something else. One of the flaws that we have in the United States is that our healthcare system doesn't want to pay for that. They don't want to pay for more aggressive testing. And yet it's so incredibly important that if we find a patient with lesions, we treat those so that they're not suffering in pain. Okay, but what about the patients who don't have lesions? What about the patients who are not responding to bladder therapy? So here are the confusable disorders. Number one, just a UTI, obviously. If you have a history of urine culture, positive urine culture, it's a consistent history of feeling better on antibiotics, then they want you to do a urine culture, a semen culture, and a prostatic secretion culture, maybe even next generation testing to see if we can identify what that is. Number 2, tuberculosis in the bladder. This is a thing. This is a thing throughout much of the world. It is absolutely possible to get tuberculosis in your bladder, especially if you've traveled to the Middle East, if you've traveled to Asia, India, etc. So how do we know somebody might have tuberculosis in their bladder? Number 1, their urine cultures are going to be negative. Number 2, they've got a history of exposure, perhaps by traveling. And there are some other symptoms that are suggestive of tuberculosis. Okay, the third thing we're going to look for is bladder cancer. If you are a smoker or you have a positive family history of smoking or you had a lot of exposure to secondhand smoke, man, we got to have a very simple urine test called a urine cytology. The urine cytology will allow the doctor to check your urine to see if you have any cancer markers. The odds are they've already done that. Anyway, it's a normal part of the diagnostic workup. Okay, here we go. They're calling it inflammatory cystitis of identifiable causes, which I basically call a chemical injury. So that's going to be ketamine. If you've used ketamine, we know ketamine damages the bladder. We know BCG damages the bladder. Eosinophilic cystitis, if you've taken a medication that we know can damage your bladder, they're going to look for any history, especially of ketamine use. Okay, overactive bladder. We want to see if you've got overactive bladder. So overactive bladder is a neurological condition that's characterized by frequency, urgency. But let me explain the difference. If you're running to the bathroom suddenly because you're going to leak, you feel like you're going to leak, that's overactive bladder. If you're running to the bathroom to reduce pain, that is a mucosal issue with the bladder wall. Overactive bladder nerves, I see more direct problem with the structure and tissue of the bladder wall. Okay, they're going to look for bladder outlet obstruction in men and women. Is there an issue with your bladder's ability to empty? And they would normally do a urodynamics, or they would just look for what we call post-void residual after you urinate, do a little sonogram, see if there's still urine in your bladder. If there is, then maybe there's an issue with your bladder's ability to empty itself. Maybe your bladder neck is tight, or in some cases, we actually see pelvic floor muscles that make things really tight. Okay. We were going to look for what we call neurogenic lower urinary tract dysfunction. So this means, is there any history of neurological disease like multiple sclerosis or Lou Gehrig's disease? We're going to look for bladder stones. A bladder stone is like a kidney stone that's stuck in the bladder, or sometimes bladder stones grow out of the bladder wall as a result of injury. They're very sharp. They hurt. If they're in your bladder and they're floating in urine, they're going to cut your bladder and you're going to be miserable. We're going to find that with a cystoscopy and or a CAT scan. We're going to look for a foreign body in the bladder. Is there something in your bladder that's not supposed to be there, like mesh? So if you've had a prolapse repair, a rectocele, cystocele repair, and they used a mesh, sometimes that mesh moves through tissue and can penetrate into the bladder wall. Sometimes sutures can do that. Patients who have a foreign body in their bladder may have more blood in their urine. And again, we would see that with a cystoscopy or a CAT scan. We're going to look for kidney stones. And so glad to see this. A urethral diverticulum. So what is a diverticulum? A diverticulum is a pouch. So let's say you have been straining like a beast to empty your bladder, like you push as hard as you can. Okay. What happens when you do that, and you should never, ever do that, is you basically weaken the muscle to the point that it starts to protrude. So if your bladder's like this, but you strain, now you got a pouch like this coming off of it, here, like this. There's your bladder, there's your pouch. Well, and that can happen in the urethra too. And we have seen a number of patients. I have worked with a number of patients. Their number one complaint is urethral pain. And yet they get diagnosed with a bladder disease and they get treated with bladder therapies, and nobody's really focusing on the urethra. And we had one patient who for years, I mean, she saw a multitude of doctors. She kept saying, it's my urethra, it's my urethra. They never did imaging. They just kept saying it was her bladder. Finally, it was a nurse practitioner who said, let's get some imaging. Let's get an MRI. And they found it. She had a giant diverticulum off of her urethra. So here's her urethra, here's her diverticulum. Same length, same size, little tiny tube connecting them. And the diverticulum was holding old urine. It couldn't drain and it was getting really infected. So they went and surgically fixed it and she was cured. Okay, what gynecological things do we want to rule out before we make a diagnosis of interstitial cystitis? Well, obviously an STD, sexually transmitted diseases, which are unfortunately on the rise in some areas like chlamydia or gonorrhea or herpes. So what are the signs of an STD? Discharge, urethral pain, vaginal pain, itching, and if you have herpes, then you have herpes lesions. Second thing we're going to look for is some of you are going to go, oh, we're going to look for a vaginal infection of ureaplasma or mycobacteria or corynebacterium or yeast. Okay. How many I was just working with a patient last week who had a wicked ureaplasma infection. Okay. So that can cause urethral pain, urethral and vaginal discharge, vaginal itching and discomfort. Okay. We're going to look for pelvic congestion syndrome. Pelvic congestion syndrome patients basically have a problem with blood vessels. They've got a blood vessel that has become dilated and blood pools in that and creates this heaviness. So somebody with pelvic congestion syndrome, you can have all the symptoms of IC, frequency, urgency, pressure, pain. But what makes you different is that generally you sleep well. Oh, why do I have my earbuds on? Okay, hold on. You sleep well. And then you wake up in the morning and your symptoms start like as the day goes on. And as the day goes on, you've got more pressure, more discomfort, more frequency, more urgency until by the end of the day, you feel like you're carrying a bowling ball around in your pelvis. That's actually blood. That's actually blood accumulated in this swollen blood vessel. This is fixable. Oh, and so this patient ends up in this crazy cycle where every single day their symptoms get worse, but they go to sleep, their symptoms go away. When you lay down, all the blood moves back into other parts of the body. As soon as you sit up, gravity pulls the blood down, and then it starts to pool in your bladder again. Okay, we're going to rule out pelvic organ prolapse. We're going to rule out atrophy. Okay, we're going to rule out endometriosis. We're going to rule out cervical, uterine, or ovarian cancer. We want to rule out pelvic inflammatory disease, and we want to rule out vulvodynia. Okay, let's go to the bowel. What are the symptoms in the bowel that can mimic IC and trigger IC symptoms? It can be irritable bowel syndrome, which we know is very strongly correlated with our widespread pain phenotype, but also cancer. Like seriously, get your colonoscopies when you need to. Do that stool test, checking for blood every year. Very, very important that you do that. We're going to look for pelvic inflammation too. So if you've got abdominal pain, fecal urgency, incontinence, diarrhea, blood and stool, fever, when I have a colonoscopy, see if we can figure out what that is. Okay, now let's get to muscles. We're going to rule out pelvic floor tension. So does this patient have pain in the abdomen, back, or perineum that is associated with urinary, bowel, or sexual dysfunction? And are their muscles tight on examination? If you are, you're not in the bladder pain syndrome group, you're in the myofascial group, you're in the muscle group. Okay. We're going to look for hernia. We're going to look for arthritis. Do we have arthritis in a hip joint? This patient may have pain in the hip, groin, buttock, stiffness after periods of inactivity, reduced range of motion, tenderness or swelling on examination. We're going to look for, is there any sort of disc disease? Is there anything that's compressing the nerves that normally support the bladder? Okay. So it's really great because here's the harsh reality. A lot of patients have these related conditions and they just haven't had the workup. They haven't had the correct workup for it. And worse, you've been told you have interstitial cystitis, so you just keep doing bladder stuff, which will never get you where you need to go. If you've got pelvic floor tension, you've got to be doing pelvic floor physical therapy. If you've got pelvic congestion syndrome, listen, a bladder treatment isn't going to do a damn thing for that, but we can fix that. They can fix that. And if there's even a remote chance that you might have cancer or anything else like that, for God's sake, let's check it quick. If you got a history of cancer, man, we got to check that out. I mean, a history of smoking, we want to work on that. We want to know what that is. Speaking as a cancer patient, the earlier you catch it, the better the better your prognosis is. Okay. So let me go back to, let's see, hold on. I got so many pieces of paper here at my desk. It's ridiculous. Now, listen, I geek out about a lot of this stuff because obviously I've spent my whole life working on this. So you have to bear with me here and let me just kind of geek out a little bit for you. Okay, so let's go back to, that one I have to talk about. Let's see. The European guidelines. So this is kind of a messy, or the French guidelines. This is kind of a messy example of all the different conditions that can be found in chronic pelvic pain. So we've got IC, we've got patients who are bladder centric, we've got patients with pelvic floor, we've got patients with centralized pain, and we've got patients with Hunner's lesion. So let's talk about that. So not every IC patient is the same, right? Hunner's lesion is a very, very distinct group. There is no doubt about that. We call that a phenotype. Hunner's lesion patients deserve their own research. They deserve their own treatment. Then we have patients without Hunner's lesions who have frequency, urgency, pressure, pain. And they have a small bladder capacity, but there's really no understanding of how and why that's happening. So that's a distinct group. Here, hold on. I want to get this right. Oh, hold on a second. Okay. Here, hold on. Bear with me. Bear with me. Or maybe it is this one. Hold on. I was reading all these yesterday. Getting super, super excited. Okay, here we go. So in Europe, what they're doing is for patients without Hunner's lesions, they're calling them IC/BPS. For patients with lesions, they're calling them IC Hunner's lesion disease, IC/Hunner's lesion disease. And now when we get inside that IC group, there's going to be patients who are very clearly bladder centric. They call it primary bladder centric. So they can only hold 500 milliliters of urine or less. Their bladder capacity is fairly small. and their bladder looks very, very inflamed, but they don't have any other conditions. It's just really their bladder wall. That's one group, primary bladder centric. So, for example, that could be the diet soda drinker, somebody drinking a lot of diet soda every day. There is another group that's called secondary bladder centric. These are patients who have all those symptoms but have an associated autoimmune disease, specifically rheumatoid arthritis, Sjogren's syndrome, or lupus. We've never seen that before defined. I think that that's really interesting, that an autoimmune condition that affects your entire body has the potential of affecting your bladder as well. And then our last group is going to be patients who have pain outside of the bladder. So this is our widespread pain group. So these are the patients who might have IBS, vulvodynia, TMJ, fibromyalgia, et cetera, et cetera. We call that chronic overlapping pain conditions. So the bladder-centric patients are the ones who do best with bladder therapies, like a bladder installation. The widespread pain patients, where it's all being driven by the nervous system, are not. A bladder installation is not going to do much anything for them. They need systemic therapies. They're going to calm their sensitive nervous system down. So now we know why so many patients haven't gotten better on bladder treatments, because their symptoms aren't necessarily being caused by their bladder. Their symptoms are being caused either by an autoimmune disease or, more importantly, an injured, damaged central nervous system. Okay, so that's kind of cool. Let's see here. I'm going to be doing a really big article in our magazine. Like, I'm just almost done writing our summer magazine, and this will be the last article I write for it. So if I'm a little scattered right now, it's because it's all new for me. I just started reading this yesterday. The patient does not have lower urinary tract symptoms. Confusable conditions must be ruled out. Okay, we know that. To direct treatment appropriately, it is important to determine whether the bladder is the primary generator of the pain, or whether the bladder is generating pain as part of another condition, like a systemic autoimmune condition, or whether the pain is perceived to arise from the bladder, but it's actually the result of a neuropathy, a centralized pain. Okay, that's cool. They want doctors to use a body map now to ask you if you have pain on the different parts of your bladder, so that they can identify the widespread pain group. And I see your questions, guys. Just hold tight. Let me just go through this a little bit. If you have pain on bladder fill, that's a very clear sign that we're dealing with a bladder-centric patient. In contrast, if you have pain with your periods, pains with sex, pains in your lower back, for men, pain when you ejaculate, for women when you orgasm, that's pelvic floor. And that's what they say right here, which is what we've been saying all this time. Special attention should be given to differentiating primary myofascial pelvic pain and bladder-centric IC. Both can cause painful urgency and frequency symptoms in the absence of an identifiable bladder pathology. Okay, they want all patients to do a voiding diary so that they can document your frequency. Let's see. All patients should undergo a pelvic floor examination. Pelvic floor muscle tenderness has been reported in 47% of men, 63% of women with urologic pelvic pain syndrome. I believe that it's much, much higher than that, and I know other doctors who believe that. They want to probe for a urinary tract infection for sure. But at the same time, they acknowledge that a patient could have Hunner's lesions and still have a bacterial infection. So one does not exclude the other. I see patients just like anybody else can get a bladder infection, which is why, we really don't recommend using a hotel hot tub or a bathtub, right? Because those are going to be pretty big risk factors. They want any evidence, blood in the urine, to be properly assessed and a urine cytology done to rule out cancer. They're getting very aggressive on that. Particularly in women, pelvic floor tension as a reaction to pain or urge is often seen as the cause for lower urinary tract symptoms. And so combined treatment for IC and the pelvic floor is required. In other words, you do not walk away from the pelvic floor work. If your muscles are tight, you work on the muscles. They're talking a bit about cystoscopies. When should a cystoscopy be done? And they say here, most patients with IC, especially younger patients under the age of 50, with satisfactory functional bladder capacity are unlikely to have Hunners, and therefore you may not need to do a hydrodistension with cystoscopy. But the Europeans absolutely believe 100% that everybody should have their bladder looked at just in case you do have Hunner's lesions, because if you do, we want to treat it. And remember, one of the causes of Hunner's lesions is mononucleosis Epstein-Barr. And so if you have a history of mono, then that's important. Let's see. This is interesting. Okay, here's something else that I found really mind-blowing. The presence and extent of Hunner's lesions are indicators of the severity of the disease. So they're talking about during a hydrodistension. The presence of bleeding from Hunner's lesions should be noted, and areas of bleeding from non-Hunner's lesions should also be noted, as this may represent an as yet unknown bladder-centric phenotype. So if your bladder bleeds anyway, even though you don't have Hunner's lesions, they're like going, we don't really know what that is. We want to note that. And they also report that glomulation, the finding of little red dots on your bladder during hydrodistension, is often the result of the exam itself and are not considered particularly meaningful anymore. Let's see. And they're really, really focusing on bladder capacity. They believe that if your bladder capacity is under 500 mLs, that's a sign that we are dealing with a bladder wall dysfunction. But if your bladder capacity is huge and way above that, then that kind of pushes you away from the bladder wall group. Okay, let me go to your questions, and then I want to talk about this other set of guidelines here real quick. So bear with me here. And I don't know why your comments are hidden. Hello, Judy. Judy says, whenever I lift to try and strengthen my bones, my muscles get tight. Okay, well, we have to figure that out, and we have to work on that. I don't know why. Frey says, what's your opinion on Valium suppositories? Valium suppositories are awesome for some patients. I mean, especially after a sex-induced flare. I mean, it delivers the muscle relaxant directly to the muscles that are in tension. And so vaginal Valium suppositories are very, very popular and very, very effective. Frey says, you're worried about dependency? Well, you know, I don't see vaginal Valium suppositories being a daily thing. If you're using vaginal Valium suppositories every day instead of going to physical therapy, I think that's a mistake. Because in the end, muscles are hands-on. We have to work on those muscles. We've got to rehabilitate those muscles. We got to get those tight muscles relaxed and released. And Valium is a way of breaking yourself out of a very painful flare, but Valium isn't going to fix the underlying problem. So if you are having incredibly consistent, persistent pelvic floor tension, you need to be in physical therapy so that they can work on that. And if you can't afford physical therapy, as so many patients can't, if you can at least go once so that a physical therapist can tell you which muscles are the problem, left side, right side, levator, obturator, piriformis. If you can walk out of that pelvic floor assessment with the name of the muscle that's messed up, then you can go over to YouTube and you can watch videos that will describe how to rehabilitate that specific muscle. It's very important that you not try to do this on your own. You've got to have an expert touch your muscles to tell us which muscle is a problem. I was working with a patient on Friday who was doing Kegels. Her doctor told her to do Kegels. She didn't leak. She had pain. I'm like, wait, you're not supposed to do Kegels. Kegels are excluded. They are not recommended for the treatment of IC because for most of us, our muscles are tight. The last thing we want to do is something that will make our muscles tighter, like a Kegel would. Instead, we have to relax and release, but relaxing and releasing pelvic floor muscles is difficult. You know, they talk about a rose unfolding. So like when you do a Kegel for a woman, and this is probably true for men too. Here, I'm going to do one right now. When you do a Kegel, it's kind of like making a tight rosebud, for lack of a better term. And then when you relax out of the Kegel, the petals open. It opens up. So it gets tight and then it opens. Tight and opens. So we don't want to focus on the tight. We want to focus on the opening. And so having a physical therapist guide you even just once a year, if you can afford it, it's so incredibly important so that we know what we're dealing with. You know what you're dealing with. Understand too that, listen, if your pain is on one side, okay, listen, the bladder is not on the left or right side. The bladder is right over the pubic bone. So if you got pain over on the left side, girl, that's not your bladder. That's probably a pelvic floor, but it could be an ovary. It could be a number of things. If you have pain by your hip bones, that's not your bladder. That's probably related to your pelvic floor. If you have pain in your glute, that's not your bladder. That's a giant muscle. As I'm sitting here right now, I have a vibration in my left glute. It's my old nerve injury that is just constantly haunting me. It's just a vibration. The longer I sit, the more the muscle quivers. Okay? Not the bladder. Betsy said, just had fulgurations and feels so much better. Excellent. So a fulguration means that they are cauterizing any open wounds in your bladder. Because if you have an open wound in your bladder, urine gets into that open wound and hurts like a bitch. You know, God forbid you drink orange juice and you have a wound in your bladder. It's going to hurt, just like alcohol on a wound would hurt. So, and if you had a bloody nose that won't stop bleeding, they will cauterize it. Well, that's what fulguration is. They cauterize the wound in the bladder. Frey says, I had bladder Botox for the first time 5 months ago, and it gave me extreme pain on urination. I never had pain. What is your opinion? Well, what it did is it probably put you into urinary retention, Frey. So the problem with Botox is that it silences nerves temporarily. So it basically turns nerves off. And so the goal behind Botox therapy in the bladder, as they inject the bladder with Botox, is they're trying to silence the nerve that's driving frequency and urgency. But they always run the risk of silencing the nerve that helps you pee. And if they do that, you can develop urinary retention. And all of a sudden, guess what? You can't pee, or you have to push hard to pee. So if you find yourself straining after having Botox, that's because the Botox has silenced that nerve that normally helps you relax and release urine. So my guess would be that maybe, just maybe, you're in a bit of retention and you're pushing, and that might be why it hurts. Especially extreme pain on urination. So I guess what I would ask you, Frey, is where specifically is the pain? Is it in the urethra or is it in the bladder? Samoy says Gemtesta has given her great relief. Good. Gemtesta helps to silence the nerves in the bladder wall. So Gemtesta can, calm things down. Hello, Kayleen. Hey, just talking to you a little while ago. Nice to see you. Hi, Kathy. Thank you, hun. Brick says, if you fall under a small bladder capacity, inflammation, pinpoint bleeding, widespread pain, the longer this has gone on, well, no, Brick, they're making a very, that's an excellent question. Because if you have an injury, as so many patients, like I was just working with a patient who had a broken tailbone. Again, broken tailbone is a classic injury that creates the foundation for IC in so many patients. If you have an injury that has not been treated effectively, or if you're in long-term pain over time for one reason or another, that the risk is that it begins to sensitize proximal nerves near the injury. And so many IC patients report that just a gentle touch on their abdomen hurts. We call that allodynia. That certainly, I went through a long phase where you couldn't touch my belly without me being very, very uncomfortable. And then if that continues to progress, we start to see this sensitization spread throughout the central nervous system. So then these patients will get very sensitive skin, a wicked sense of smell, etc., as that central sensitization kind of moves. This is why we want to find the pain generators and treat the pain generators, whatever they are, to calm that nervous system down. The guidelines, like the European guidelines that I was just going through, they were not specific on how small bladder capacity inflammation should be treated other than Elmeron, which of course we don't want to use because it's now associated with blindness and bowel disease. Elmeron it was the only approved medication for IC. It is widely used around the world. It is a bladder coating that kind of covers the wounds in the bladder or covers the mucosal layer of the bladder, thereby protecting nerves and protecting the tissues. Unfortunately, it has now been associated with retinal damage that can progress to blindness and inflammatory bowel disease. So Elmeron has now fallen out of favor because of these really significant risks. The company has paid $43 million to patients so far. There are more lawsuits that are still in existence, and there will probably be more as more of the bowel research emerges. It's very concerning to me that the European groups are actively promoting Elmeron, and I didn't see any warning about the adverse events of Elmeron in these guidelines, and that really bothers me. I think patients need to know that this medication, especially if you use it for longer periods of time, more than 3 years, has the potential of affecting your vision. And I was working with a patient again, like on Thursday, who she was still taking 3 a day. She'd been getting her eyes checked regularly. And finally, at her last exam, they found it. And it was severe. And her question now was, oh my God, it finally happened to me. What do I do? And my answer to her was, well, let's look at other things that can coat your bladder and protect your bladder that are not associated with those risks, which again, here in the States is going to be a chondroitin-based supplement. It's the closest that we have. In Europe, you've got chondroitin installations. You've got more options in Europe than we do here in the United States. So the longer pain persists, the greater the likelihood that the nearby nerves are going to become affected. We call that neural crosstalk. Mary says, pain that feels like heavy menstrual pain from the bladder down the vagina to the rectum. What's going on? Urinalysis is negative. Well, Mary, if it's heavy, if it feels heavy, you want to get screened for pelvic congestion syndrome, because that's the symptom of that we associate with dilated blood vessels, this profound heaviness. And some patients describe it as they feel like they're carrying a bowling ball around in their pelvis. And then as soon as they lay down, again, the blood redistributes and their symptoms get much better and they sleep well. Then they get up the next morning and the cycle begins again. You would go to an interventional radiologist to get checked for that. Frey said the urogynecologist recommended 2 baths daily for the pain. Heat relaxes muscle. I will tell you, when I was in the thick of vulvodynia, when I was in high school and college, I took baths every day. I absolutely felt better when I took a warm, if not hot bath. I mean, every day after school, I would do that. When you're older, though, and you are in estrogen atrophy, hot baths on the vulva are not necessarily the best thing. Then we go to warm or lukewarm. Patricia says, I always have trace blood in my urine. Is that common? That's very, very, very common. And I've always had microhematuria also. Every time they've ever done a urine sample for me, they always find microscopic blood, despite the fact that my bladder is perfectly healthy and there is no sign of any dysfunction going on. And so 30 years ago, 20 years ago, 15, even 10 years ago, the doctors are like, yeah, that's common in IC. But in our latest guidelines, they've kind of done an about face on that. And they've said, okay, if you see persistent blood in their urine, even microscopic blood in their urine, at least do a urine cytology test. Let's just make sure that we're not dealing with maybe an early cancer patient, because that's like the number one thing we'll look for in cancer. So is bladder cancer is going to be blood in the urine. I was convinced that I was dying of cancer in 1993. I was obsessed with it. I did not believe them when they said I had interstitial cystitis. I said, I'm dying here. I believe that I am physically dying right now. I believe that I have cancer. I believe that you have missed it. And I demanded exploratory surgery. I did, and I got it. I mean, literally my OBGYN, Dr. Bennett at the time, was like, really? And I went, oh, hell yeah. I can't get it out of my head. I think I'm dying of cancer. Because the pain of IC is rated equivalent to the pain of cancer, terminal cancer. So that's a normal response to such intense levels of pain. Now, of course, I did not have cancer. But I'm really glad I had the laparoscopy, because it helped me stop worrying about it, because I was obsessed with it for a good 6 months. But there's no connection between IC and cancer at all. I've never seen any direct connection discussed in any study. The only thing they say is sometimes patients get misdiagnosed with IC. And so all they need to do is a very simple urine cytology test that looks for cancer markers in urine, and that will tell us. So if you were a smoker, or you live in the home of a smoker and you're exposed to a lot of secondhand smoke, ask for a cytology. The odds are they probably already done it, Patricia, anyway. They just didn't tell you. Mary says, what about fecal suppositories? I don't know what a fecal suppository is, Mary. Phrase says, doctor said physical therapy and Valium suppositories daily. I agree with that if you're early on, like let's just say you've got muscles as hard as concrete and they're just trying to break this cycle of muscle tension. Makes total sense to me. But I don't, if we have to pick between physical therapy and vaginal Valium suppositories, we're always going to fix the physical therapy. Because when you work with the muscles, they relax and release. Physical therapy, Valium suppositories are temporary. Physical therapy can be permanent. It can fix it as long as you're persistent. And remember, one of the questions I always say to patients because there are a lot of patients who drop out of physical therapy. And they're like, well, it's not helping me. Why should I pay for that? I don't want you to do that. What I want you to do is I want you to ask the physical therapist, are my muscles responding to therapy? Like, are they improving? So you went from concrete to cardboard and from cardboard to, I'm talking textures. Are the muscles slowly releasing over time, or are the muscles always locking back down into tension? If your muscles are always locking back down into tension, which is probably why physical therapy isn't getting you where you need to go, we need to figure that out, because that's usually bones. That's going to be a bad hip, a SI joint, broken tailbone, bad knee. But in most cases, it's just your feet. It's how your foot hits the ground. There's a problem with how your foot's hitting the ground that is redirecting abnormal forces right up into your pelvis and making your muscles tight. So ask your doctor, are my muscles responding, or are they always getting tight? If your muscles are always getting tight, don't give up. That's just a new question. Why? Why are my muscles always tight? Frey says, what about, Emcella chair? I don't know what you mean by that. Hello, Bonnie. Nice to see you, honey. Amanda says, I will never do Botox again. Had to self-cath for weeks afterwards. Yes. And it didn't help my symptoms. I know it helps some, though. Yeah, but in the end, Botox doesn't fix anything. And that's really the difference between where we are in 2026 versus where we were in 2000, is we don't just want to manage the symptoms. We want to find the underlying problem and treat the underlying problem. And the role of Botox, now that we're phenotyping, has gotten very, very small. So Botox, we're really going to look at that for that patient with a small bladder capacity and frequency urgency, most likely. Frey says, is burning in the bladder not the urethra when the bladder fills and urination? Do you recommend cystoscopy to see any irritation? Yeah. Don't you want to know? Like, I have a rule for me. If I'm in pain, I want somebody to look at it and tell me why I'm in pain. If I'm bleeding, I want somebody to look at it and tell me, where's the blood coming from? And I don't like guessing. I like facts. And it's without allowing somebody to look in your bladder, you are forcing that doctor to guess. And that's just not good enough, in my opinion. We need more clear information, because here's the deal. If they look in your bladder and you have a perfectly normal, healthy bladder, then guess what? It's not your bladder. It's something else victimizing your bladder, usually tight pelvic floor muscles, but it could be a fibroid tumor pushing on your bladder. It could be pelvic congestion syndrome. It could be widespread pain. It could be a number of things. So having a cystoscopy, and a lot of patients are just like, so they agree to the cystoscopy because they're peeing every 15 minutes. Like, I've had 3. I would do it right now. If my doctor wanted to look at my bladder, I'd do it on camera. I'm not worried about a cystoscopy at all. It's what I call a looky-loo. They just numb the urethra, stick the scope in, look around, pull out, you're done. They might put a little fluid in there to help with the field of vision. But it allows them to look more closely at your bladder. And then if they see something funky like a Hunner's lesion, then they're probably going to ask to do a hydrodistension with cystoscopy under anesthesia in the doctor's office, so that if they see anything, they can treat it and they can biopsy it. You don't want to be awake for a biopsy. It would hurt. You definitely want to be asleep for that. So you've got in-office cystoscopy, OR, or you've got in the hospital outpatient hydrodistension with cystoscopy. And there's a place for those. Amanda said, surprisingly, Flomax has been amazing for me. I started about a month ago. My symptoms are so much better after trying every type of drug and pill there is for the last 3 years. Excellent, Amanda. Glad to hear that. Flomax is not considered a treatment for IC, but quite a few doctors whip it out for women. It's more commonly used in men, especially men with benign prostate hyperplasia, to help them urinate, if I remember correctly. But if it's helping you, good for you. Mary said she tried 5% lidocaine patches, no relief. Well, a lidocaine patch is going to focus on nerve sensitization near the skin. So if it didn't touch it, that tells us that your pain is not at your skin. Your pain is deeper. Robbie said, what is a urine cytology? It's not psychology, it's cytology, Cytology. It is you just pee in a cup and they send it to the lab, and they're just looking for what we call cancer markers. And odds are everybody in here who's been diagnosed with IC, you've already had it done. It's a normal part of your diagnostic workup. But if, for example, you started bleeding heavily and you were peeing blood in the urine, they would absolutely do a cytology just to make sure we're not dealing with kind of a new onset cancer situation. Here's the thing about bladder cancer. It is the easiest cancer to treat with the best success rate. The earlier you catch it, the easier it is to treat. So it is considered kind of the easiest cancer out there, as long as you just don't let it progress. Don't wait 4 years before you have your test. Get it done. Hi, Nancy. Nancy says, my urogyn advised me not to start pelvic floor physical therapy right away. He said he wants to treat with baclofen, gabapentin suppositories at first to calm the pain down. I would like to also get started with physical therapy as well. It's hard to know if the pain is nerve or muscle. Doctor also wants to do a pudendal nerve block as well, first before pelvic floor therapy, to try and determine the muscle versus the nerve pain in the rectum. Nancy, I agree with him, because the nerve block would be very diagnostic for you. And if injecting a nerve block turns your pain off, then we know we're dealing with a nerve. So there's nothing wrong with what he's saying. All right, you guys on YouTube. Oh, hey, you're talking. Hi, you guys. Julie said, what are the urine cytology tests called when trying to rule out cancer? It's just called a urine cytology. That's it. Julie said, why can't I see questions on the YouTube video? Because they're on Facebook. Because I'm live streaming on 2 platforms right now. I'm live streaming on YouTube and live streaming on Facebook. And so there are always a lot more people on Facebook than there are on YouTube at the beginning. Hey, Jane, nice to see you, hon. I hope you're doing well. If you want to watch it on Facebook, you go to facebook.com/interstitial cystitis network. You have to spell the whole thing out. I'm sorry. Because I foolishly put IC network to my personal account. And you can't change it once you've done that. I did that 15 years ago. Didn't understand it. So facebook.com/interstitial cystitis network. Frey says, my cystoscopy was fine earlier last year, but my doctors don't agree with doing a cystoscopy now, which I requested because Botox caused me pain because of waiting for Botox to disappear by 6 months. Well, Frey, if your bladder was fine and they saw nothing wrong with it, it's interesting that they chose to do a bladder therapy. So they might have done that if your bladder capacity was small. Generally, now again, like I'm reading all these new guidelines and it's making me look at things a little bit differently because our knowledge of IC is just evolving every year. Every single year, things change. And so it's really interesting now to see the Europeans focus on and using a smaller bladder capacity combined with frequency urgency as a distinct patient group as compared to patients who have a normal bladder capacity with frequency urgency. And I'm unclear what the treatment protocol is between those two groups. They're not really talking about that well. Brick says, what is an IC specialist? It's a doctor who specializes in interstitial cystitis. There are a small number in the United States who do specialize in IC, specifically Robert Moldwin on Long Island, New York, the former Robert Evans at Wake Forest, who is now retired. He was our top specialist in the country. He retired last year for medical reasons. We've got Ken Peters up at Corewell Health, northwest of Detroit. We've got Dr. Henry Lai at the University of Iowa. We've got Dr. Elise Day, who is in New York. We've got, so there are the older original experts, the old timers are kind of, everybody's getting close to retirement, myself included, because I'm an old timer. Now we have the next generation that's coming along. But finding and identifying them is difficult. The top next generation, and he's like in his 50s, is Dr. Henry Lai at the University of Iowa, and he's brilliant. He was on all these guideline committees, and he teaches the IC course for AUA, and he loves phenotyping, and so, which is great. Mary, I'm not familiar with that, hun. I am not familiar with the Mankowski pain scale. Brick says, how can we find one that specializes in IC? Brick, over on the IC Network website, we have a doctor list. Find a care provider. It's in the IC pull-down menu. You put your zip code in there, and it will give you a list of the doctors that patients have recommended, as well as doctors that do research, IC research, who are usually quite good. I will just tell you right now that it is very, very, very difficult to maintain these lists. And so some of those doctors on our list may have moved on, and we go through them about once a year, but it's a very time-consuming thing to maintain a list. Let me tell you, not the funnest thing in the world. All right, let's go back to these guidelines here for a moment. So in the French guideline, the new French guidelines for IC, what are the risk factors? They say being a woman is the main risk factor, with women being 9 times more likely to be diagnosed than men. But you notice the language, to be diagnosed than men, because a man with lower urinary tract symptoms is usually diagnosed with chronic prostatitis. when many of them actually have interstitial cystitis. First degree family history, and if you have anybody else in your family, your immediate family, that is a 17-fold higher risk. Let's see here. Gastrointestinal disorders in childhood. A very recent study sought to identify risk factors for developing IC in adulthood. Irritable bowel syndrome during childhood showed the highest hazard ratio at 2.9. Chronic inflammatory bowel disease also showed a high hazard ratio. Also, UTIs in childhood were considered a predisposing factor for developing IC in adulthood. And of course, autoimmune diseases like rheumatoid arthritis, lupus, and Sjogren's syndrome. Okay, now let's okay, this is interesting. So let me go back to my markers here for a moment. Okay, hold on. Okay, I need a new piece of paper. Hold on. Okay, so, and let me, here, I gotta look at my screen to see what you're seeing. Okay, so remember that there is a broad group of patients with bladder pain syndrome. And in that, there are different types. There are patients with a small bladder capacity without lesions. There's patients with a large bladder capacity without lesions. Okay, so, and Hunner's lesions are, again, a small subset of the overall IC community. Okay, so let's look at this. So now the French look at it in, so you guys, again, I only just got these yesterday, so you got to bear with me because my brain's kind of spinning right now. The French believe, Jane says here, hold on a sec. It's crazy how much has changed since I was diagnosed in 2014. I was told I had moderate IC based on my hydro, but now we all know normal bladders have what I had when I distended. I now know mine is 100% pelvic floor driven and pelvic PT. Okay, so the French are doing, they're being even a little bit better with phenotyping here. And so let's see. Okay, 1, 2, 3, 4, 5, 6. They are citing 6 phenotypes. So again, in our, actually, you know what? I can go back to this. So in our, well, can I? Hold on. No, I can't. Shoot. It's complex. Okay. So here's what the French think. Okay. The first group is bladder pain. Okay. And so the bladder-centric phenotype is what they call the Hunner's lesion phenotype. So they have daytime and nighttime frequency, no other pain conditions, and you see the lesions. So this, let's just call this HL, Hunner's lesions. Okay, their next phenotype that I think everybody would agree with is nerve driven wide. Okay, whoops, get back up there. Okay, this patient is different from this patient. So for any of you who have overlapping pain conditions, very sensitive skin, wicked sense of smell, you're in this group. You're not in this group, you're in this group more likely. Okay, their next one here muscle. And we now know a lot of patients are driven by muscle problems, myself included. Okay, so that's a distinct patient group right there. Okay, then, and where they say IC is associated with pelvic floor pain dysfunction. It is often characterized by myofascial pelvic pain and voiding dysfunction with functional obstruction. That means your muscles are so tight it's hard to pee and it's obstructing urine. And so anyway, okay, so they're saying the patients may benefit from pelvic floor therapy focused on muscle relaxation, alpha blockers in case there's voiding dysfunction, and trigger point injections into muscle knot. Okay, here's the next one. Allergies. Allergenic cystitis. IC-BPS associated with multiple allergies. These patients may respond particularly well to antihistamines, primarily cimetidine, hydroxyzine, or desloratadine. I've never heard of that before. Okay. So if you're allergy driven, then we want to do medications that can calm that allergenic response. Okay, here's one that's a lot of people are gonna like. Recurring infections. IC mediated by recurring infections. These patients experience recurrent UTIs with persistent pain between episodes, may benefit from infection-targeted treatments such as antibiotic prophylaxis and oral immunotherapy, like we're working on the UTI vaccines right now, and even bladder installations with antibiotics, where you just put the antibiotic right in the bladder. So that's going to make the people online who believe that, I mean, there are very people who are very, very outspoken about recurring UTIs, and they make ridiculous statements like, we all have a recurring UTI. We don't, but some of you might. And it's not just bacteria. It could be a recurring fungal infection. It could be a recurring candida infection, or it could be a recurring viral infection. And then their last group is OAB, overactive bladder, which is a very specific nerve issue with the bladder. Okay, so 6 phenotypes in France: bladder pain, Hunner's lesions, nerve-driven widespread pain, pelvic floor tension, overactive bladder, recurring UTI, and allergies. Okay, so now we know why bladder therapies didn't work. I mean, is a bladder treatment going to help with allergies? No, you need an allergy med. Is a bladder therapy going to help with widespread pain? Absolutely not. It might temporarily protect the nerves, but a lot of that pain is being driven by nerves that are injured in the central nervous system. And these are the patients who are going to do best with things like antidepressants, which calm nerves down, or PEA. And we now believe that the great majority of patients, we've got one study that shows that 87% of IC patients are in this group, the pelvic floor group. And that these patients doing bladder therapies are pointless. What instead we want to do is we want to get these muscles to relax and release. All right, let me keep going. They say here in IC, true urinary urgency is uncommon. The IC patients don't run to the bathroom because they're afraid of leaking. IC patients run to the bathroom to reduce pain. Boy, is that the thing of my life. Okay. Whew. In those early days, I still remember getting stuck on a traffic jam on the Golden Gate Bridge with a full bladder, and I was driving. I don't even know how I didn't leak in the car. I was rolling in pain, sitting in a car on the Golden Gate Bridge. Ridiculous. Okay, now here's what they say. Here are things that indicate that you might not have IC. If number one, you've got large voids, like you can pee like a horse. If you can pee like a horse, maybe it's not your bladder wall. If you don't have frequency, maybe it's not IC. If you have incontinence, maybe it's overactive bladder. And if you've got visible blood in your urine, then we need to figure that out, because that's usually not IC. Oh, let's see here. Hold on, let me keep going. Imaging. Oh, this was really interesting. So are there any other testing that can be done that would help a doctor identify? So generally the first test, aside from a urine test, the first test to physically study your body and or your bladder is usually an ultrasound. And they will do an ultrasound just after you pee in the office. You go leave a urine sample, and then you come back, and they're going to do an ultrasound to see if you were able to empty your bladder. Because if you weren't, that's very, very meaningful. Brooke, hold that thought. I got a lot of thoughts on InterStim. Just that's not what you think it is. So bear with me, okay? So ultrasound is going to find, it's going to look at your bladder capacity. It's going to look to see if there's any issues with your ureters potentially, and any abnormalities with your kidneys. A CAT scan is useful for identifying structural abnormalities, like if you have a tumor, or perhaps, and it will also look at the thickness of your bladder wall. And so it's considered somewhat helpful in patients with Hunner's lesions. But it's not a recommended test for IC, only if the doctor suspects that there's a problem. MRI appears to be the most promising imaging modality. It provides excellent soft tissue resolution and does not involve radiation, and is a really great way to see if a patient has endometriosis that might be affecting their bladder. So that's very cool. On the cystoscopy, we already talked about that, but it should be noted that petechial hemorrhaging and glomerations caused by hydrodistension are very common, and should not be relied upon alone for diagnoses. So we've thrown out the finding of petechial hemorrhaging and glomerations as diagnostic for IC. They had some pictures. You want to see? These are pictures, and they're not the best pictures, but these are some pictures of Hunner's lesions. I don't think these are really very good pictures, though, to be quite honest. But this is a really good picture of, you can see all those little red dots. That's what happens when you stretch the bladder. So we thought that was IC. Now we know that that's just what happens when you stretch the bladder. And then these right here are what they call submucosal hemorrhages. And that was important because it means that the bladder wall is fairly fragile. And if it tears, it will tear during hydrodistension. Okay, hold on. Okay. So this is the protocol. So you're at the doctor's office. Sorry, I was gardening if my fingers look weird. Here you've got urinary symptoms longer than 3 months. You go to the doctor. The doctor is going to do a history. The doctor is going to do an examination. The doctor, and that's going to include the pelvic floor. You'll see pelvic floor muscles. They're going to do the imaging like the ultrasound. If they need to, they're going to do a cystoscopy with hydrodistension if they suspect Hunner's lesions. Once they have that information, they can do your phenotype, which then gives you a personalized treatment plan. That's it, my friends. That's it. That is it. That is critical now. All right. Now, again, I'm just kind of going through this randomly because my brain is still absorbing all this new information, but there will be a big article on this over on the IC Network website and in our magazine. Can a bladder atrophy? Okay, hold on. Dolphin says, can a bladder atrophy due to lack of estrogen? Absolutely. That is the foundation for atrophy. It atrophies because it does not have enough estrogen. All right, let's go to Brooke over here on Facebook. Brooke says, if you cannot tolerate medications, what are my thoughts on InterStim? InterStim was developed here in Northern California. My first support group that I started in 1993 was filled with the early InterStim patients. I will tell you that it was horrific back then because they did not use enough anesthesia or any anesthesia for their trials. And we had a lot of patients who were very badly traumatized by InterStim. The fundamental flaw or fundamental concern with InterStim is that every single month there are hundreds and hundreds and hundreds of adverse events filed with the FDA. This is not easy. When you put a medical device in the human body, things can happen. And when you put a medical device down in the lower part of our body where there are higher concentrations of bad bacteria, infections can happen. And one of our biggest adverse events with InterStim, sacral neuromodulation, is the introduction of bacteria into the surgical field and into the surgical wound. And quite a few patients have gotten MRSA and other infections in the wound. The device can fail. The device can move. Patients can be shocked. There are just, and I can show you exactly how you can look at those yourself. I have a really big section on InterStim over onto the IC Network website. But two kind of fundamental points here. Your treatment needs to be based on your phenotype. Okay, so a lot of companies made a lot of money 20 years ago because they, it's like, hey, just give every patient this, give every patient that. So that's why so many patients were given bladder treatments, which we, of course, now we know is pointless because so many of us have pelvic floor problems rather than bladder wall problems. And so today, the role of InterStim has gotten quite small. And it's really only done when we think we're dealing with dysfunctional nerves. And I don't know if I haven't seen anybody write yet if it's ideal for somebody with a low bladder capacity or a higher bladder capacity. What I do know is that if your symptoms are being driven by estrogen atrophy, we need to treat the atrophy. Interstim will do nothing other than maybe modulate your symptoms a little bit, but it won't fix it. And our number one goal is to find the underlying problem and fix the underlying problem. We don't just want to chase the symptoms anymore, which a lot of IC therapies have done. I mean, we want to treat the symptoms, but far more importantly, we want to find what's causing the symptoms in the first place and treat that so you don't have the symptoms anyway. So, again, if a patient has a Hunner's lesion caused by a viral infection, is Interstim going to heal that lesion? No. If a patient's symptoms are being driven by widespread pain, central sensitization, is it going to help? I don't think so. I don't, and in fact, you know what? You know who talked about it? In here, I can get the reference. Curtis Nickel, when he proposed his phenotypes, he was the only one who really talked about where Interstim applies now. Let me see if I can find that. Okay. There is an article on our website that talks about, a whole section on phenotypes. So let me see where he saw primary storage symptom syndrome. Some IC patients run to the restroom to reduce pain. Their frequency and urgency is being driven by avoiding the pain caused by bladder filling. Dr. Nickel believes that these patients can benefit from antimuscarinic medications if the pain has been controlled, like Mirabiron, for example, will help with frequency, urgency, and pain. He believes that bladder training is essential to increase bladder capacity. Quote, as a last resort, Botox A can provide short-term pain relief, though it carries some risk of urinary retention. And he says here, sacral neuromodulation has helped some patients, but Dr. Nickel did not believe that it significantly improved pain. And just out of curiosity, let's just see, let me go over to the American IC guidelines of the American Urology Association, and let's see where they put Interstim treatment with respect to phenotyping. So here, hold on a sec. I know exactly where it is. So, all right. So read online. Okay. So now I'm at the IC guidelines, and I'm just going to search. Well, here, hold on. I don't even need to do that. Let me see procedures. Okay, it's statement 21. Okay, so let's go here. Our national guidelines are really excellent, comprehensive guidelines. And they're arranged. Okay. A trial of neuromodulation may be performed if other treatments have not provided adequate symptom control and quality of life. Okay. Three studies reported findings from a permanent implant. It is important to note that neuromodulation is not currently FDA approved for IC treatment. However, many patients meet the frequency urgency indication for which it is approved. Yeah, and man, they're really not even defining which phenotype that it would be the most beneficial for. They just say if the other treatments haven't worked, you can give this a shot. Okay, so Brooke, the other really big issue with InterStim is cost. We had a patient who was a nurse in a hospital. She lived in a small town. There were 3 urologists in her town. Every doctor told her she needed to do InterStim. She really didn't want to do it. She felt like she was being forced to do it. She called me and what do I do? And I was like, well, I don't know what you should do. I mean, they're saying they won't treat you unless you have this done. And you know, it was offered fairly aggressively. So she was very, very smart. She talked to the billing officer in her urologist's office. Is this covered by my insurance? They said yes. She then called the hospital where she worked, where they were going to do the surgery. Is this covered by my insurance? They said yes. Then she called the health insurance company to double check them all, and said, is this covered by my insurance? They said yes. No written pre-authorization is required. She didn't get it in writing. She should have gotten that in writing, because a week later she had a bill for $75,000 and a threat to garnish her wages. And she called me back and she said, I would have never done this at that price. I can't afford it. Now they're threatening to garnish my wages. And it's, you know, and she went back to all of them. You told me it was covered. They said, we're sorry, we made a mistake. It's like, not good enough. So what I would say to you, Brooke, is, and always get it in writing. Never believe anybody. Like, you need it in writing. You have to have it absolutely in writing from your insurance company that it's covered. Because then if they come back and say it's not covered, you got to say, look, here's the evidence. And you know, you've got good ammunition and evidence that they can't force you to pay that you would never have agreed to do that procedure if you had known that you were going to pay for it. But I mean, again, I'm just really concerned that you're turning to a surgical treatment because you have drug sensitivity. That's part of the widespread pain phenotype. If you have very sensitive skin, wicked sense of smell, if you're sensitive to medications, if you're sensitive to smells around the house, that puts you in the central sensitization group. And there are other options like PEA, palmitoyl-ethanolamide. PEA acts to calm nerves down, and it has an outstanding safety profile. That would be something that you could try before resorting to surgery. And again, there are hundreds of FDA, and you know what? I'm just going to do it. And you know, I can actually, and here, hold on a sec. Dolphin says, is vaginal estradiol cream best treatment for bladder atrophy? Yes, it is. Okay, so you guys on YouTube won't see this, but you guys on Facebook are going to see this. So, because I'm going to share my screen here. So hold on one second. All right, so there's my desktop. Okay, so you see my computer right now. Okay, and here, hold on. Let me do this. I need a new window. And I'm going to search for something called the MAUD database. The MAUD database is the FDA database that tracks adverse events to medical devices. So here we go. And I'm going to type in model, or actually brand name, InterStim. Okay? And you always have to look at the date. Don't just do the last month. Let's just start from January 1st of this year through June 30th of this year. Okay, so we're at 6 months. Okay. 500 adverse events filed in 6 months. And actually 500 is the limit for how many they can do, if I remember correctly. So let's just look at a couple of these real quick. Malfunction. Medtronic submitted a report. Information was received from a friend or family member regarding a patient with an implantable neurostimulator for urinary and bowel dysfunction. It was reported that the patient is having trouble with their stimulator and can't get it adjusted because it won't connect. Anyway, caller mentioned that they did not get a new handset. So this is a technical issue with it. And you can see there's all sorts of issues, kind of high-tech issues with batteries and things like that with this one, and messages on the handset. Let's go to the next one. Another malfunction. The recharger is not working, battery light scrolling and unresponsive. Okay. Let's go to the next one. Serious injury. Information was received from a consumer via a manufacturer representative regarding a patient with an implanted stimulator. It was reported that the patient had an MRI in the hospital. Patient states she had a brace over her pelvis during the MRI. Patient states she was in the MRI mode at the time, and during the MRI towards the end, patient reported the battery feeling very hot and a painful zap down her leg. Patient reported to the MRI tech this was happening. The MRI tech responded per patient that they were almost done. Patient reported this to another tech, and the tech responded that they might have been left in too long. Patient reports she's had intermittent pain and the battery is feeling randomly hot at times. The patient was advised to turn off the device and see the provider in the office. The device needs to be replaced. So remember, an MRI uses magnetic resonance to examine a field. If there's anything metal in there, it's going to get hot and it's going to burn the tissue. And so she probably suffered with an actual burn from the MRI around where the leads were or around where the generator was. It's very difficult. If you've got interstim and you're in a major car accident and they're trying to figure out why you can't walk, they won't be able to do it. Depending upon the device you have, they might not be able to do an MRI. Let's go to the next one. Serious injury. Patient was implanted with an implantable neurostimulator for incontinence and urinary dysfunction. Patient developed a seroma at the pocket site, needed to be adjusted. The pocket was not healing. The cause was unknown. It's unknown if the issue was resolved. It's probably an infection, but I can't say that for sure. Let's go to the next one. Another malfunction. Device stopped working. The caller stated that when they tried to program it, it would work right away, and then it stopped. And every day that it was on, it was getting stronger, and they could urinate, but then they couldn't urinate. The caller said they didn't know whether to turn the stimulation up or down. Their bladder started feeling hard as a rock and wasn't urinating at all. They only peed twice in one day. Okay. Yikes. Let's look at this one. Serious injury. Patient with an implantable neurostimulator for urinary dysfunction. It was reported that they had the wrong device implanted in 2020. So in 2021, they had the correct device implanted. Patient noted the original one was implanted on the right side, but the second replacement was implanted on their left side. Don't know why that was an injury. Just a couple more. Another malfunction. Another malfunction. That's interesting. Patient, let's see. It was reported that the patient reported a therapy issue. Patient said they contacted their managing doctor and was told to reset. Patient reported that both during the day and at night they were going to the bathroom constantly. They experienced pain and wetting themselves, stating that it had not been pleasant. Patient said they needed to figure out what they were supposed to be doing because the therapy was not helping. The patient said they were feeling shocks around their urethra and said, if I could get this out of my body, I would. The patient mentioned experiencing symptoms throughout the night and having to change pads frequently. The patient asked what the tinkling sensation is supposed to do. Okay. Last one. Serious injury. Patient was reported they had the implant procedure done twice. During the first surgery, it was too near the skin, so they needed to go through another surgery. Okay. And this is my frozen. I can see you guys talking, but my screen is frozen there. So hold on a sec. All right. So as you can see, InterStim is not easy. InterStim, of all the therapies out there, is probably the most at risk for, adverse events, if not serious adverse events. The last time I counted, there were about 20 fatalities associated with it. The last one was like 3 years ago around the holidays, and it was I think it was a man who'd had it, and his doctor had either retired or moved away. His device became very, very infected. He was incredibly ill. He was at the emergency room. They could see the infection. They had no InterStim expert. They contacted the company, if I remember correctly. You know what? Here, hold on. I can actually. Here. Give me a sec here. So let's go back to the mod database here for a moment. And I can actually show you how to look for that. Okay, so again, we're going to put in the brand name InterStim. And this time, we're going to search for death. And let's go back to 2015. Okay. It's thinking. All right. So there are 16 records reporting fatalities. So this latest one, okay. No, actually, the latest one was received from a family member regarding a patient with an implanted neurostimulator who died hours from the procedure, and we don't know why they died. And that's the fundamental flaw with this database, is it doesn't necessarily give us more information. Let's go back to this one. Yeah, this is the one. Information was received from a healthcare provider regarding a patient who was implanted with the neurostimulator. It was reported that the healthcare provider called to report that the patient had major surgery. After the surgery, patient developed a sacral ulcer, and the InterStim lead is exposed in the sacral wound. Caller said they had to use cautery and that they may remove the lead. Caller said the issue started in the last couple of weeks. Caller said patient was admitted to the hospital. Caller said patient no longer has InterStim managing doctor because the previous doctor has moved. And then additional information here was received in a follow-up letter. The letter response reported that the major surgery was caused by or related to the Medtronic device. They indicated multiple deep debridements, 2 inches, to immobilization and development of a grade 4 ulcer. And then when they were asked if the issue had been resolved, their answer was that the patient had died. Okay, so there are, you know, for anybody who says this is easy, you have to understand there are issues. PEA, also known as palmitoyl ethanolamide, is a supplement that I first learned about more than 20 years ago because we had some American doctors who were importing it for their IC patients because it acts by calming nerves down and reducing pain. The problem was 20 years ago is that it was very, very expensive. So it really fell off my radar. It cost thousands of dollars. But then in 2019, PEA research had expanded dramatically across Europe, and they did an IC study that was presented here at the American Urology Association conference in Chicago. And it reported that 87% of patients reported a significant and progressive reduction in pain over time with no adverse events reported, if I remember correctly. And the doctors were quite excited that they could recommend something for pain that was not an opiate and there was no risk of addiction. And so there are 2 different PEAs on the market. Let me show you. Oh, here they are. So the PEAs that were developed because of that research study are Peora and P-Leaf. And this is what I take because, again, I have a healthy bladder. My problem is not my bladder. My problem is my muscles and nerves. I am very, very focused on calming muscles, relaxing muscles, and calming nerves down. Hello from Germany. Hi there. It's nice to meet you. I'm a little scattered here and it's very hot, just like it is for you guys. So bear with me if my appearance is not, you know, it's a little casual today. All right. Let me go back here to Facebook. So remember, we are live streaming on YouTube and Facebook, and we will be here as long as you have questions. We have a lot to talk about because we got all these new guidelines that just came out. Frey says, why do they say Axonics is MRI compatible? Probably because they've used different materials in it that are more MRI friendly. I don't know what those materials would be. Let me just do a quick, let me go back to mod. I won't do this. And let me just put in Axonics and let's see. Okay, hold on. I got to reload this page. And let's see. Okay, so this time I'm putting in brand name Axonics. And I'm going to search from January 1st. Let's see what comes up there. 387 adverse event reports. First one, serious injury. It was reported that a recharge-free IPG had a premature battery depletion. The device had to be replaced. The patient is expected to fully recover. Let's look at the second one. Serious injury. It was reported the patient contacted the company to file a complaint saying the system caused severe debilitating pelvic floor muscle spasm disorder. Patient reported seeking evaluation and treatment from multiple healthcare providers without relief while the device was implanted. Patient reported undergoing a device explantation and stated that the pain and discomfort resolved once they removed the device. That's compelling. Let's just do a couple more here. Another serious injury. The patient had pain, discomfort, and aching at the implant site after losing weight, and they had to have surgery to revise the pocket that was holding it. Here's another one. Device caused severe, debilitating pelvic floor spasm disorder. Symptoms got progressively worse and were unbearable. The device was implanted in 2023 and was removed in 2026. Muscle spasms ceased to occur after the device was removed. Here's somebody who had the device removed because the pocket site hadn't healed. The pocket is where they implant the device. Another serious injury. It was reported that during a permanent implant, there was trouble disconnecting the lead from the extension cable. One of the electrodes was blocked, yada, yada, yada. Okay, so as you can see, it has issues too. Just Google mod database and you can search for yourself. Amanda says, I am one of those that is in those FDA reports. Hun, I've been telling patients to file with the FDA for 20 years. The early days were just brutal. And I mean, there were so many complications with it. Patients were so greatly traumatized. I had one gentleman in my group, I couldn't even say the name of the doctor that invented him without him standing and wanting to hit the wall. He was so traumatized by what happened to him. I mean, the device is better now in the sense that it's smaller. It doesn't, they fix a lot of the earlier problems. But as you can see, hundreds of adverse events filed every month is a concern. Emily said, I found this study from South Korea that seems to be interesting for the future, but I'm wondering if it's for people with Hunner's lesion. Let me look at it. Let me take a look at it. I pay a lot of attention to Korea, to be quite honest. I think their medical care is exceptional. A research team has identified a previously unknown disease mechanism underlying interstitial cystitis. The findings were published in the latest issue of Experimental Molecular Medicine. All right. So they took samples of the bladder wall of Hunner's lesions and non-Hunner's lesions, which they say help them enhance, or they say it significantly enhanced the relevance and reliability of the study. They also looked at genes. Researchers identified a complex multicellular network in which stromal, immune, and vascular cells communicate through intricate signaling pathways to drive disease development within the bladder. They said that inflammatory immune cells become activated in diseased tissue and promote abnormal vascular remodeling. They found excessive activation of a signaling pathway between vascular cells and muscle cells, leading to structural changes in bladder muscle and excessive bladder contractions. They say this is why some patients experience severe chronic pain despite having no apparent abnormalities in the nervous system. What year was this? No, it's just published a week ago, 10 days ago. Huh. Again, we have groups, right? So we got the pelvic floor group. We got the widespread pain group. We got the Hunner's lesion group. We got the estrogen atrophy group. That's very clearly a group in the bladder pain cycle also. So I think what they're describing, okay, let me use this as an example. Now, I haven't read the study, and so I don't know the details. But imagine having very severe estrogen atrophy, or imagine having, let's do a Hunner's lesion. Let's say you've got a Hunner's lesion. And remember, Hunner's lesions, we now know, can be caused by viral infections, specifically mononucleosis, etc. Okay, so we've got a open wound in the bladder that every single day is being irritated and provoked by whatever's in urine. Ammonia, urea, acid, you name it, it's in there. So now we have a wound that is being structurally challenged by severe toxins, basically 24 hours a day. So the question then is, how does that affect the cells in the bladder? I mean, obviously they're going to become very inflamed. But the question then is, how does the bladder tissue respond to persistent daily chemical trauma? And what did they use here? So they said, researchers identified complex multicellular network in which stromal, immune, and vascular cells communicate through intricate signaling pathways to drive disease development in the bladder. But what if it's not a disease process? What if that same thing is happening because urine is getting where it's not supposed to be and irritating everything, irritating the vascular cells, irritating the structural cells, irritating nerves, et cetera, et cetera. And their study found inflammatory immune cells becoming activated in diseased tissue and promoting abnormal vascular remodeling. So again, think about a profoundly irritated wound that is desperately trying to repair itself. And so you've got the immune system that's sending white blood cells to the area, and you've got the healing process beginning. You've got stem cells that are trying to grow and adapt and heal the wounds, for lack of a better term. We have no, and then what does the human body do when it's trying and struggling to heal? Well, what does it do? It starts to send a lot of blood to the area, because blood delivers nutrition, blood delivers oxygen, blood delivers white blood cells. And so we have known that some IC patients have a lot of abnormal growth of blood vessels in the bladder wall, like tiny blood vessels. And so is it a disease, or is it the result of tissue that's trying desperately to heal itself? It's a good question. If we would know so much more if we didn't have to deal with the effects of urine. You know, it makes care very, very tricky. All right. Brooke says, thank you so much for explaining this. I have my hydro, cystoscope, pelvic floor Botox, trigger point injections on Tuesday. A month later, I will meet with the gynecologist and urologist to discuss how I'm doing, their recommendations for my bladder. Can I set up an appointment after surgery? Yeah, honey, you can call anytime. You can call tomorrow if you want. Just call. I mean, our phone number is at the top of our website, but I will. There you go. I do patient coaching all the time, every day. And if it's just a couple of questions, I mean, 98% of the coaching is entirely free. But I will always end those conversations with, hey, if you found this helpful, please think about becoming a member of the IC network or making a donation, because we have to pay the bills. But I never, the way my office is set up is it's first come, first serve. And so I always take calls in the order that I get them every day. So if you call and you get a text back from me that says, I'm sorry, I can't talk to you right now, that already means I'm working with somebody else. Just leave a message and I'll call you back when I can. And sometimes I call back later. If you're back east, remember I'm in California. I usually work till 5 or 6. So I might call you at 8 o'clock at night. But just be patient. I try, and you have my permission to be the squeaky wheel. It is perfectly okay to call multiple times. You just have to understand that my days there's no set schedule because it's driven by phone calls. Arlene says, does lactoferrin help heal IC with no Hunner's lesions? Can I take it with PEA? The lactoferrin study found that red inflamed bladders became pink and healthy regardless of if they had Hunner's lesions or not. So I would consider that a very encouraging and worthwhile thing to try. And can you take it with PEA? Sure. Neither one of them is associated with any significant adverse events, and PEA is not associated with any known drug interactions that I know of. I'm not sure about lactoferrin, but PEA for sure. Well, Google it, search for it yourself, because new research comes out all the time. I think I last searched for PEA drug interactions like 2 months ago. All right, Dolphin says, I'm still recovering from full mesh removal. The mesh eroded into my bladder 3 times. I've had a few bladder surgeries. How do I report this to the FDA? You go to the MOD database or MedWatch. Just Google MedWatch, and I think you file it there. Oriki says, EMDA therapy, electromotive drug administration, is a urological treatment procedure in which drugs are transported deep into the tissue of the urinary bladder using weak electronic. Yeah, honey, I met with the CEO of the company that invented it because they were actually studying it with IC, but then they sold it to a bigger company who stopped working with IC. So I'm not sure. Now, maybe things have changed. Honestly, I haven't looked at EMDA in a long time. I mean, the CEO flew out to California to meet with me years ago. Here, hold on. But again, another company bought it. A big pharmaceutical company bought it. Let's see what I think their goal was, either UTI or cancer. IC fell off the table with that. Yeah, Euromed. It was the delivery of lidocaine. That's what they did. They studied delivering lidocaine into the bladder wall for IC patients. Ulrike says, is it available in Germany by Amazon? No. Well, no, actually, it could be. You need to search for let me give you the scientific name. We can't send to the European Union. They do not want any supplements from America. Search Amazon for that. That's the scientific name, palmitoyl-ethanolamide. Amanda said with her InterStim, it malfunctioned, strongly shocking me randomly, would not turn off. Also an infection at the surgical site. It was awful. I'm sorry that happened to you, hun. You know, I mean, healthcare right now is being driven more by profit than it is by results. And I feel like, I mean, we know, for example, the FDA has been approving medications with no study showing that they help. And that really bothers me. And that so our standards have fallen greatly. Amanda says, and that was only 2 years ago. Lori, did you have a message there for me? I saw one and then it disappeared. Oh, Ricky, what medication did she give you with the EMDA? Was it lidocaine? Amanda says, I was stupid because my doctor kept pushing me to get it, guaranteed it would fix my issues. You know, I have to be careful with what I say because I don't want to be sued, but back in the day, there was, okay, I want to say the right words here. What I witnessed at conferences and from talking with various people was that InterStim was kind of pushed, by saying, hey, those IC patients that annoy the hell out of you because they call all the time, the ones who flare and they take up a lot of office time and they just are annoying. Well, you can get rid of them by doing this surgical procedure. I mean, that's not exactly what was said. That's an impression of what was said 20 plus years ago, 25 years ago. I don't remember who, where, when, but I just remember a marketing approach that was like, man, those IC patients that annoy you, well, if you do this one surgical procedure, they might not annoy you anymore. It was a long time ago. And so, doctors kind of jumped into it big time. And some doctors just, I had one patient call me. She had seen a doctor in Colorado who told her the only treatment for IC was InterStim. And so she did it and she had a problem with it. And then she started looking at other sources and she started reading more. He didn't even tell her about the diet. He didn't tell her about anything other than he just said to her, you need to have InterStim. And so she had it done. And it was a moneymaker back in the day. I don't know if it's a moneymaker now. So our goal now, in fact, that's exactly why the IC Network started selling supplements. That conversation with that patient, it dawned on me. in working with her that patients needed to know all of their options, including over-the-counter supplements. And that was when, and they needed to learn about it from, in a evidence-based, research-based way. And it infuriated me so much that this patient had major surgery before she was even told about the diet, much less the non-invasive alternatives, because at that time, our AUA guidelines, they started with the easy, less invasive therapies in a stepwise approach, like a ladder. Surgery was a last option, it's not a first option. And the AUA guidelines at the time, the first was diet modification, water intake, anxiety management, which is so incredibly important. Step 2 was oral medications, bladder instillation. Step 3 was pelvic floor dysfunction. I think step 4 was Botox. And I think they stuck neuromodulation in step 4. This was in 2014. And then Botox was originally in step 5. They moved it to step 4. And then big surgeries were the final step. So it just infuriated me that they didn't give her the easy stroke before they went to a surgery, which, as you know, based upon what we just saw in the FDA database, has significant side effect, potential adverse events. Hold on a sec. Frey said she was also persuaded to do it, but again, the meds aren't working, so she doesn't know what to do. So again, Frey, we need to figure out what your phenotype is first. Lori said NAC infusions. Amanda said, when I started having these issues, the doctor and the rep for the company completely blew me off. I had to go somewhere else. Absolutely. That's like the other thing is, and specifically, because we've done a ton of InterStim support. I mean, because we have our whole IC Network support forum where there's a whole section on neuromodulation, including a board on complications. And I had a patient call who had it done. And so she had the trial. And the trial went really well for her. She immediately felt better. And she was like, yeah, man, I want the permanent. Let's do the permanent. I mean, her symptoms were significantly better during the trial. And so they did. When she woke up from the permanent implant, she immediately knew there was a problem. Immediately knew. It didn't feel right. It didn't feel the same. And so just like you, she's like calling the doc, hey, it doesn't feel right. And what they said to her, like the first month was, well, you're just healing. You just have to heal first. And here it is, it's getting worse and worse and worse. And she's calling the company, calling the rep. It's, guys, there's a problem. There's a problem. It hurts badly. And when they finally opened her up, like 6 months later, and again, this is my best memory because this was years ago, her belly was filled with rusty battery fluid and she had gangrene because the device had broken on implant. And the doctors didn't listen to her. And I talk about that on our website, that one of the challenges here is, the doctors have high hopes it's going to work, for sure. And sometimes they simply don't listen well when a patient says there's a problem. And you, Amanda, have experienced that. And this other patient had experienced that to the great degree because she had permanent nerve damage from the gangrene. If they had literally just listened to her and gone back in a week later, they could have prevented all that. But they just kept saying, you're healing, you're healing, you're healing. And so I think that you have to have very firm, a very firm understanding with the doctor who's implanting it, that you expect them to listen to you, and not to push you off if something is happening. We had another patient who her device started shocking her. Every time she had a bowel movement, it shocked her, like every time. And it was not a little shock. It was, ow, this really hurt shock. And she had lost her job. So she'd lost her health insurance and she was on Medicaid. And the doctor who implanted it refused to see her on Medicaid. So here she is with a device malfunctioning. And the doctor refused to care for her. And she called me crying, what do I do? What do I do? I'm being shocked every day, multiple times. Well, I mean, she was being shocked every day whenever she had a bowel movement. And I said, let's call the company. You gotta call the patient company, because it's their responsibility, in my opinion, to make sure that patients who have their device have care. And it turned out in Florida, there was only one doctor in the entire state of Florida who would accept a InterStim patient on Medicaid, and she had to travel. And then we've had patients who are being shocked, and the doctor says, that's normal, don't worry about it. And then you call the company, it's like, no, nobody should ever be shocked. If this device is shocking you, there is a fundamental problem here. I think it's hard for some doctors to admit that it's disappointing for them when it doesn't work, because they really sincerely wanted it to work, as I really truly believe that doctors are acting with the best of intentions to try to make it better. But I think some doctors have trouble acknowledging the fact that there might have been error. It's hard to say. Amanda says they billed her insurance for $38,000. One of the questions that I had, there were so many explants in the early days, and because there were so many infections. And my question was, well, who owns the device? I mean, your insurance paid $38,000 for it. You paid $7,000, so $45,000. Did you buy that device? Did you own that device? If you did, then when they took it out of you, what happened to it? Because at some point in time, there has to be an assessment of what happened with that device. What made it shock you? And that's where there's just a lot of grayness. Because if I'm harmed by a medical device and I own that medical device, then God damn it, I want the report showing what happened to that medical device. Why did it malfunction? I deserved that. I paid $45,000 for it, right? And yet the devices just kind of disappear. In some cases, the devices are thrown away. In other cases, they might be sent back to the company. But there's a whole missing trail where we just really don't know. And I think that that's an important piece of this puzzle here. Like in the fatalities, did the devices get sent back to the company? Are those companies required to issue a report as to the status of that device that would have led potentially to a fatality. Frey says she has constant urgency and frequency. Hey, Linda, nice to see you, hon. I hope you're doing well. I'm not up on the NAC research, to be quite honest. I have to look at it again. And acetylcysteine. Amanda said, yes, when I asked them if they were going to study the device, they said no, they just throw it away when they remove it. Okay, I mean, my God, how will we ever know if there was a manufacturer's error or a problem with the device that caused your problem? That's like hard data evidence. And I don't understand. I don't understand the process for what happens to devices that are removed that are associated with severe complications. I would assume that they would never be thrown away. I would assume that they would be cleaned, sterilized, and sent somewhere for an examination, because this is actionable potentially. I mean, if they could prove that the device broke, how many devices? I mean, we don't know. We have no clue what's going on here. And I'm very, very uncomfortable with that. Frey said, should they have replaced it with a new one? Not necessarily. Well, number one, if it's all the result of infection, no, you can't do that, because you have to deal with the infection first. Sometimes they pull one out on one side and put it on the other side. And so, but again, Frey, it's just managing symptoms. It's not fixing anything. And we have to try to find the problem and fix the problem. So if you, for example, have a fibroid tumor pushing on your bladder, that could cause all of these symptoms. And we can fix that and we can cure that. If you have a pelvic floor injury, as most patients do, physical therapy can fix that. So I'm very focused on not chasing the symptoms with treatments. I mean, there's nothing wrong with making sure you're comfortable, but the most important goal is still a proper diagnostic workup to make sure that we haven't missed anything. Amanda says, no way in hell would I have that again. And so, you know, when I started this meeting, I was reading, because this is the first time I've seen a really, really good discussion of the conditions that mimic IC that need to be ruled out. And here, hold on a sec. Papers. Here it is. Okay, so again, Frey, these are the things we want to look for. Number one, a chronic bladder infection. If you have a history of positive urine cultures, then maybe do a next generation DNA urine test. We want to make sure, if you've been traveling, make sure it's not tuberculosis, because tuberculosis can affect the bladder. We want to make sure that it's not bladder cancer through a urine cytology test, especially if you were a smoker. We want to make sure that you don't have an injury to your bladder wall from a caustic chemical like ketamine or chemotherapy or BCG or a drug-related cystitis like Augmentin is kind of known for irritating the bladder. We want to make sure that there's no neurological disease that could be related to your condition. So if you're an MS, a multiple sclerosis patient, that could help us understand the history of urinary symptoms. A bladder stone, a foreign body in the bladder like mesh or a suture or surgical clips, or a diverticulum is our little. I was working with a patient who had a nice little pouch. Imagine a little balloon off the side of her bladder. She had strained so hard, she popped a diverticulum. Thankfully, it was near the top, so it didn't collect a lot of fluid, but it was there. Sarah says, when I was initially diagnosed, I thought frequency, urgency, and incontinence were symptoms of IC. These are the symptoms of overactive bladder. That is true. Incontinence is not a symptom of IC. It's not. Now, can some patients have incontinence, like stress incontinence? Yeah. But that's often the result of aging or injury. But incontinence by its very nature is not a symptom of interstitial cystitis. Okay, what else are we going to look for? We're going to look for an STD, which is hysterical because so many patients, like when my IC started, I hadn't had sex in like 3 years. I mean, I was not in a sexual relationship at the time. And they're like, we're going to test you for every STD. And it's like, why? I'm not in a relationship right now. And so everybody gets tested. That's okay. They just have to do their due diligence. We're going to look for unusual vaginal infections. We're going to look for pelvic congestion syndrome. Pelvic organ prolapse, often missed. Patients who have muscles that are weak, that are no longer holding structures in place, like the bladder and the vagina and the uterus. Things start to fall and they can press on the bladder. We're going to look for atrophy from estrogen atrophy. We need to look for endometriosis. We need to rule out any reproductive cancer, prostate cancer in men, uterine cancer, cervical cancer in women, and even urethral cancer, because HPV is out there and it's hurting a lot of people. The human papilloma virus is a virus that comes in many different families, and some of those families are incredibly leave you at incredible risk of very severe cancer. And that cancer can affect the urethra, it can affect the vulva, it can affect the bladder, anywhere from HPV. So that HPV vaccine is really important. It's saving lives. We want to check for vulvodynia. We want to check for the bowel, pelvic inflammatory disease, IBS. We want to check for the pelvic floor. We want to check for hernia. We want to check for arthritis in the hip joint. Osteitis pubis. I'm not sure what that is. And spinal degenerative disc disease, nerve root compression. What is osteitis pubis? Anybody know what that is? I think I looked it up and I've forgotten what it is. Osteitis. Oh, here, I did look it up. It's right in my history. Let's see. Inflammation in the joint between your pubic bones. Okay, isn't that interesting? So just because you have bladder symptoms, it doesn't mean you have a bladder disease. The bladder can become the victim of many other things happening in the pelvis. Dolphin says she got bladder stones from the mesh when it eroded the second time. A cystoscopy diagnosed bladder mesh erosion. Yeah, I'm not surprised, hon. And those bladder stones are a bitch. I can show you guys a picture if you want to see one. Here, hold on a sec. Ah. Hold on a sec. I got lots of pieces of paper. Ow. Oh, and I got a sore toe. Okay. Good night. Let me show you a picture of a bladder stone. There you go. Imagine having that sucker grow out of your bladder wall. You can see that it's rough. It has sharp edges. And the thing is that what all the research has shown is that stones are covered by bacteria. So here you have basically a sharp rock that is potentially floating in your urine, cutting your bladder wall. And because it's covered with bacteria, it's introducing bacteria into the bladder wall. So bladder stones are formidable. And of course, they can block the urethra. You want to see what cancer looks like. There you go. There's cancer. That is a tumor, and it's white. Now remember, cancer is the uncontrolled growth of cells, that the cell growth mechanism has been altered, and now cells are growing uncontrollably. And you can see that really easily right there. The whole thing, that all is a tumor. Let's see if I have any other interesting pictures for you. Ow. Trichinitis, you see those bumps on the bladder wall? Turns out those are little pus pockets. That was just discovered a couple months ago. Everybody thought those bumps were normal. Nope, they're little infections right on the surface of the bladder. And here's that study. It's the studies right here. All right. Dolphin said, yes, my bladder stones look just like that. I had pink blood in my urine. Exactly. I'm really glad they found them. Eddie says, do I have a good IC doctor or urologist in New York City? The only doctor that I knew in New York City was the guy who ran Central Park Urology, but I don't know if he's retired or not. Let me look. I mean, yeah, David Kaufman. He's still there. He's on 41st Street. Tell him Jill at the IC Network said hi. I haven't talked to him in years. So David Kaufman, Central Park Urology is like the only doctor in New York that I know, in New York City. And he appeared on the IC Network. He did a lecture for us years ago. He seemed like a very, very nice man and committed. All right, hold on a sec. Sarah said, okay, Julie said, will everything you just listed be available in writing? Absolutely. I will be writing that up this week. No, honey, I will be doing a big article on it for sure. probably tomorrow. I'm trying to finish up my summer magazine, and then these new guidelines came out, and thankfully I hadn't gone to print. I hadn't gone to press yet, so I am doing a last minute edition in our magazine of the new guidelines. And so, and I intend to, I'll be updating our IC 101 book, which was the first book to talk about phenotypes with the new system. You know, and basically it's just everybody now, the global standard is acknowledging that there are patient groups. We don't want to condemn everybody to incurable bladder disease. We know that that's just not true, that there are different presentations. And so we've got the bladder-centric group, we've got the pelvic floor group, we've got the widespread pain group, we've got the allergy group. What was the other one besides allergies? There are 6. Oh, come on. Here it is. Oh, and the recurring UTI group and the overactive bladder group. What's hard is that researchers want evidence-based medicine. They want a research study that proves it. It's like, okay, you tell me there are these groups, now prove it. And so much of this, especially back in the day, was like, well, who's going to pay for that research? But this is what we know as doctors. A bunch of our patients have tight muscles and they get better with physical therapy. And we got research that proves that. A bunch of our patients have Hunner's lesions. That is an undeniable fact. We have the research that supports that. But we've never had a research study that I'm aware of that delineates the allergenic group. And I truly believe that the more phenotypes we have, the better, because it ensures that they've ruled out all the other conditions. I mean, I think that estrogen atrophy is its own group. I think chemical injury is its own group. I think that could be included in the bladder wall phenotype, or is its own group, one way or the other. But the more groups we have, the better the chance that they can narrow it down and find your underlying cause. So anyway, it's got my wheels spinning because, again, I read all these yesterday. And I should have read them again this morning before talking about it, but I needed to get out and walk this morning too, which I did. I went to the park and walked. For Jill's sanity. For my sanity, I have to be outside and walk and exercise. All right. Well, we have been going for about 3 hours now. Boy, time just flew by. Linda said, are bladder stones made of calcium oxalates? I know they're made of calcium. I'm not, because they're derived from a damage to a calcium metabolism pathway in the bladder wall. But do they also have oxalates in them? That's a good question. Bladder stone oxalate? Here. Oxalate stones form from excessive calcium and oxalate in acidic urine, while struvite stones, which are composed of magnesium, ammonia, and phosphate, are exclusively due to UTIs in alkaline urine. That's so cool. If you ever took chemistry and you learned about precipitates, so you've got a liquid here and a liquid here, and you mix them together and the molecules combine and they make flakes. There's a precipitate. a powder that occurs, or flakes that occur when two chemicals are mixed together. And so essentially that's what a kidney stone is, and or a bladder stone is. A calcium oxalate stone is a result of calcium and oxalate, but you have to put them in very acidic urine to make that precipitate, make that stone happen. Whereas the struvite stones, you have to put them in alkaline urine, which I didn't really realize. Everybody, not to be a geek here, but like, when your kids are going through school, make sure they take biology, and make sure if they can, they take chemistry. I mean, get those basic skills down. They have to understand, especially from a chemical safety standpoint, that you just don't mix certain chemicals. If you do, explosions can happen. You got to be safe. Linda said, I've had IC my whole adult life, and my dad had horrible IC, and my grandma had bladder problems. My daughter has IC. Big family connection. So the University of Maryland, you have a sibling with horrible IC. We all have to modify our diets. My brother doesn't modify as much, and he suffers terribly. Lactoferrin seems to be making a huge difference for me. Excellent. So there are a couple of theories about genetics. It was Dr. Jack Warren at the University of Maryland who was the first 25 years ago to really try to look at genetic correlations. And as we read earlier in these new guidelines, if you have a first-degree family member with a history of these symptoms, then there is a significant chance that it could be passed. So the question is, what is passed? So like, my mother had IC symptom, but it began with her on her honeymoon. Her diagnosis was honeymoon cystitis. Man, listen, I grew up with every lady in my family having to use the bathroom frequently. Linda says she remembers Dr. Warren. You offered your family. Oh, yeah, he was I don't even, obviously he's retired. I don't even know if he's still alive. So anyway, listen, my grandmother was diagnosed with IC in her 90s. My mom's mom. My mom had it. I have it. My aunt had it. My sister has variations of it. So the question is, what is it? I believe that it's actually inherited nerve sensitivity. I do. We don't have, I mean, there's been a lot of new DNA research recently, and I haven't had the time to go through it, but my theory back in the day was that I had two theories. Theory number one is that I'm a redhead. Redheads have more nerves. We got 30% more nerves in our body than people without red hair. We are hardwired to have nerve sensitivity. And remember, every tribe needed somebody who was sensitive to smell the water in the food to make sure it was safe, going back a million years. Sensitivity is a vital trait for survival. So I was kind of the opinion that perhaps there was some nerve sensitivity passed along. Because again, my mother, she couldn't wear any synthetics. In fact, she had to wear cotton broadcloth bras because they didn't have cotton knit back in the day for her, back in the 50s. And she had a ton of discomfort wearing anything other than cotton. And I'm exactly the same way. You'll notice I am wearing a cotton tank top. I wear a cotton tank top under everything pretty much to protect my skin, especially my wounds, my incisions. Okay, so I think there's an inherited nerve sensitivity that's going on. In our family, we also have a lot of IBS stomach stuff that's been passed down. And so I suspect in that circumstance that our genetics does not like today's modern day food. We're Norwegian, like 100% Norwegian Swedish. Our ancestors grew up on fish and whale fat and lingonberries, and fruit only one season of the year when it ripened. Our body never learned to develop defenses against high levels of acid, as compared to people with ancestors who grew up around the equator where they had a lot of citrus and they had a lot of other stuff. So I think that how our body is wired and based upon our ancestry is important. But the other thing that we've certainly seen, and I have seen this personally in clients that I've worked with, is growing up in homes with trauma, growing up in the home where there was a violent alcoholic, a grandfather or grandmother who drank and hit the kids, and all. I remember I was working with one lady who had like 6 siblings, and they all had chronic overlapping pain conditions. But they had different ones. Some had migraines, other had fibro, some had IC. And so we can't underestimate the importance of trauma and childhood trauma in creating a foundation among many people in a family, especially if it's generational trauma. You're welcome, Julie. Julie said, thank you for doing this live video. It's been very informative. I try. You guys, if you like what I do, please come on over to the IC Network and sign up for our free newsletter. For goodness sake, I write it. We don't send out spam. And if you want to become a member and get our magazine, that would help tremendously, because times are tough, my friend. Times are tough for everybody. And I understand that they're tough for you too. It's a crazy world we're living in right now. Gas is back up to $6.50 where I live. What can you say? Eddie says, I want to try lactoferrin, but I'm allergic to cow's milk. I drink milk all the time, however, and it doesn't bother me. Should I try it? You could. I mean, the very first question that I asked the company is, what about people who have problems with lactose? And they said there's not enough lactose in there to cause a problem. But you know what you could do, Eddie, is reach out to the company in Australia. Just send them a message. I mean, if you drink milk all the time and it doesn't bother you, then how can you say you're allergic to cow's milk? Are you drinking another type of milk instead? Ulrike said, I found the medication from the EMDA. It was ropivacaine, adrenaline, and a steroid. Adrenaline? So, that's basically a rescue installation. But adrenaline, why would they do here? Hold on. Let me just see if I can. Yeah, it's standard. Adding adrenaline shrinks the local blood vessels, which keeps the numbing medication working longer and lowers the bleeding. Boy, you learn something every day. I had no idea they put adrenaline in that. That's fascinating. Man, I hadn't talked to that company in probably 15 years. Oh, I don't even remember. Was it Terrace? What was her name? Yeah, it was Terrace Biomedical. They were acquired by Johnson & Johnson in 2019. Yeah, they're using it for chemotherapy. So let me give you the context here, just for people who are curious about what we're talking about. Delivering medication to the bladder is very difficult because you have a bladder wall. And the purpose of that bladder wall is to keep stuff out of the bladder wall, right? The mucosal layer of your bladder is a thick, robust barrier that keeps urine away from the inner workings of your bladder wall, the cells, the nerves, the blood vessels, etc. And so it is remarkably difficult to put a medication in the bladder and get it to penetrate through the mucosal layer deeper into the tissues where it can be effective. So as an example, DMSO is known for its ability to penetrate the bladder wall. So they will often combine medications with DMSO just to move it through the bladder wall. They can use a liposome. A liposome is a little tiny circle sphere filled with medicine. It's got an oily construct. And so when you put that in the bladder wall, the mucosal layer will absorb it because it's oily. And that's why you see oils in supplements, whether like Sister Protect and like Bladder Builder. They all have an oil base to help transport it across the bladder wall. So with EMDA tackles it in a different way. Rather than putting it in an oil base, what they do is they deliver a little tiny electrical stimulation into the bladder, which kind of temporarily opens the channels and allows the medication to go in. And so EMDA was created by Terrace Biomedical, I don't know, like 12 years ago, 10 years ago, something like that. And they were doing a lidocaine installation for IC because I did clinical trial recruitment for them and I met with them. And it was very promising. I mean, to deliver a medication into the bladder wall where it could be the most effective at calming whatever's calming that inflammation, etc., just makes a lot of sense. But then, and I remember saying, God, this is going to be great for infections. If we can get that antibiotic past the bladder wall down to where the infection is, and cancer therapy, if we can get that to the cancer cells, that would be great. And yeah, it was invented by MIT scientists, Dr. Robert Langer and Michael Sema. So then Johnson & Johnson bought it. Yeah, it was launched in 2008. Yeah, so my timing is pretty right. So okay, so hold on a sec. Allergan, another big company, bought the IC portion of that. Well, anyway, it's I thought that the team at Terrace they were awesome. They were basically students from MIT. They were doing a good job. I really liked them a lot. I just don't know if they're still in business. No, Johnson & Johnson bought the entire company. Well, there you go. big business buying small business. Hey, anybody want to buy the IC network? I'm ready to be acquired by a big business for my retirement, please. Linda said, I use the enteric-coated lactoferrin. Yeah. Enteric is always better because lactoferrin, I think 50% of lactoferrin is destroyed by stomach acid. So the whole purpose of having an enteric capsule is to carry it across the stomach acid and down into the bowel where it will finally be released. Ricky, did you know that there's a new German IC support group? IC organization? I don't have their contact information. Apparently, they just got formed a couple months ago. Eddie says, when I was a child, I was allergic to cow's milk. It would make you congested. If I have an antigen panel done, it still shows that you're allergic to it, but you're fine when you drink it. Well, if you can drink it, then you shouldn't have. I can't imagine how lactoferrin would cause an issue if you're drinking it and it's not causing any issues, right? Yeah. Oh, Ricky, you have the Hunners. Well, so did the EMDA help? I can't imagine it helping with Hunner's lesions. Frey said, how much dosage do you take of the PEA? You showed the brands. You could do 2 a day. Arlene said, bladder rest is back ordered until Friday. Should I take bladder builder? Should I order bladder builder? Yes, you should, because we're probably not going to have bladder rest for another 3 weeks. Everything's been delayed. Everything is being delayed right now. So they told me on Friday, 3 weeks. Our bladder builder, because we did a bladder builder production run first, and that has not been shipped yet. I think that's supposed to be, the microbes are supposed to be done tomorrow. And then the next run for us is bladder rest, but it's probably going to be, we probably won't have it for a month, honey. So yes, I would get the bladder builder. And again, for those who didn't know, I have, this is the other thing I was working on this week, new covers for our guides, for our IC 101 diet guide. I did this. I did this. Anybody who might say turning 60 puts you, you should retire. Oh, I did this. There's our new flare guide. That's me, by the way. And the new cover for IC 101. And I'm working on the new pain guide. Then we're going to have a menopause guide. Then we're going to have a sensitivity guide. I am on it, my friends. I am on it. I'm either working with patients or writing. You're not going to see me. Listen, I'm not online in support groups answering questions. I've done that for 30 years. I don't want to do that anymore. If people have questions, just call me. I will talk to anybody. But you're not going to see me. You're not going to see me hanging out online in support groups anymore. I have. Yes, Ulrike, we can definitely get it to you in Germany for sure. Also, our new WooCommerce store will probably be done in a couple of weeks, which is going to help tremendously with us shipping to Europe. So you can just let me know, and I'll find a way to get it to you. Okay. Yeah. So, thank you, Linda. Arlene says you have our book IC 101. Are the new guides different? The new flare guide and the diet guide are significant expansions on what's in the book. And they're 80 pages each. One's 80, one's 84. And our IC 101 book is already outdated with respect to phenotypes. So I'm just updating info. I'm just massively trying to update as much info as I can. Yes, Ulrike is a PDF download. Yes. And right now they're on Kindle. They're on Kindle with the old covers, the black covers. I have to update all the covers tomorrow. But you can get them on Kindle right now for $6.99, I think. Either $6.99 or $8.99, I think. Pricing is very difficult right now because the minute you print, the price goes up like mad. Like literally printing one of these guides, it's like $8 to $10 in printing fees and paper fees because the cost of paper has increased dramatically. So the Flare guide sells for $18.99 in print, and the Diet Guide sells, I think, for $22.99 in print because it's just expensive. That we have the PDF files for $9.99, and then we have the Kindles for $6.99. So we're going to make it happen. I'm really understanding that everybody right now is financially stressed. I am financially stressed. Who isn't financially stressed at this point in time? And so I'm just, and the other true reality here is that I almost died. I've had a rocky couple of years. And between breast cancer and breast cancer surgery and then AFib, that literally they thought I was going to die from AFib after the COVID shot 18 months ago. And now I have AFib. So even though AFib's not fatal and I've been taking classes and it's under control and I'm on a lot of medication, I'm very, very compelled to get as much information out as I can while I can. Now, I fully intend to work for another 5 years, maybe even 10. I love what I do. What I don't like doing is running a store. I mean, it's just the back end, the technology, all that sort of stuff. It's difficult. And what I really just am not interested in doing now at all. I mean, and people ask me every day, Jill, why don't you go into the Reddit group? Why are you going these places and helping? And it's like, I've done that for 30 years, guys. I built an award-winning website rated the best on the internet by Harvard Medical School and the University of London. So if you need information, don't go to Reddit or a support group, man, go to the website. It's 30 years and it's something we work on all the time. So my priority now is I'm writing and videos. That's it. I do not have the patience to write, can I drink coffee again? Come on, I've done that so frequently. There's a video. Watch the video. Come to the website. It's all there. So I've changed, not the same girl that I was. I have priorities, but my other big priority is I love talking to patients. Like some days I'm on the phone all day. And so if you have a question, don't hesitate. You can call me. I am more than happy to talk to anybody. And I will never get better if people don't tell me what I'm doing wrong. I really appreciate people who call with constructive criticism, like something that didn't make sense, something I want to fix it. I want to make it better. So Yeah, that's why you're not going to see me online. I have no patience for it anymore. Plus, social media is just too damn. I'm sorry for swearing. I've sworn 3 times today so far. I'm sorry. That indicates my tremendous frustration with where the world is right now. But I'm here for you. And I'm more than happy to talk to anybody. Just be the squeaky wheel. Like, understand that because I'm on the phone all day, you got maybe a 20% shot at me actually answering the phone. So if I text you back, sorry, I can't talk right now, just understand I'm already working with somebody. Don't give up. Just text me back. Okay, not a problem. Call me when you can. It's fine. It's really, really, really fine. All right. Almost 3.5 hours. See, look, here's my dilemma. You want to see my dilemma? Not to get a little personal. So I'm lifting weights again, right? So I'm starting to get my guns again. But, I had a double mastectomy. And I had lymph nodes removed right here, right? So I got this stuff right here. And the funniest thing about having a double mastectomy is that you look down and you see things you have never in your life seen before. Like there was a layer of fat right here that I have now finally gotten rid of. But now I'm really focused on getting back down to my my goal is to hit 135. I'm at 145 right now. We'll see. Every day is an adventure. All right. So let me check and see if there's anything else. Now I'm here as long as you have questions. If you have a question, don't hesitate to ask. But hold on one sec. I believe that we got. Now here's a page here. It's right in my email from a gentleman in the UK with pelvic pain. All right. So hold on a sec. I'm pretty sure that yesterday I got a new alert on something new happening in the ICU world. I will tell you that on September 18th, I am one of several speakers with the International Continence Society. We are doing a patient seminar on flares. So that's going to be fun. Okay. Ooh. Well, let's see what do we have here? Lots of new things. Interstitial cystitis with Hunner's ulcers managed with Yadi Tela Udarabasti, a case series. All right. Hold on a second. Let's look at this for a moment. So this came from India. This report describes clinical outcomes of an intravesical installation here. Wait. Ooh, this is interesting. Hold on a sec. Give me a minute. I was so focused on the new guidelines, I didn't look at the new research. What the hell is this? It's an Ayurvedic therapy where sterile medicated herbal oil is administered in the urinary tract or reproductive system. It uses a traditional formulation for tissue repair, antimicrobial action, and reducing inflammation. jasmine, neem, turmeric, and daru haridra with purified copper sulfate acting as an antiseptic and a base of sesame oil. Oh, okay. Well, this is interesting. Okay, combine, hold on, combine. So they put that in the bladder. Now, obviously, please do not go and get all these ingredients and do this for yourself. This is incredibly unusual, and I'm not saying it's reasonable at all or effective at all. Hold on. Whoa, fascinating. Fascinating things you learn, right? So what's... Okay, that's just weird. They use something that eliminates toxins from the bowel. Oh, no. I don't like that. Well, okay. They say that 2 patients with Hunner's lesions, their symptoms went from severe to almost normal. And their results remained stable through a 2-year follow-up period. Huh. I don't know these researchers. The Mahakali Ayurveda Hospital and the Ayurveda College in Nadiad, India. Well, interesting. We don't know anything about this. Nothing. So I cannot make any comments on it other than it's interesting. What else do we have? Are gastrointestinal, gynecological, and urogenital chronic overlapping pain conditions predisposing or perpetuating factors for oral pelvic pain like TMJ? The answer is, yeah, it's part of chronic overlapping pain conditions. That's a no-brainer. We have the French guidelines. Low intensity shockwave therapy as a preventative and restorative therapy in men's health. That's good. Let's see what they say. A lot of doctors are now using low intensity shockwave. It's aimed at preserving endothelial, neural, and tissue integrity before irreversible dysfunction develops. Okay. More and more doctors here in the US are using it. Interesting study from China. Biomaterials and nanomedicine for mucosal repair and inflammation control in IC. So they're exploring nanomaterial-based drug delivery systems, stem cells, nanomedicine, platelet-rich plasma, and other emerging nanomaterial. You know what nano is? I mean, again, if I could go back to grad school, that'd be something else that I would want to study. Nanomedicine is focuses on tiny, tiny, tiny particles. What is the right word for it? there's a word that my brain is not going to. Nano therapies. Let me see here. Tiny particles, self-propelled nanorobots to improve drug delivery, reduce side effects, and precisely target tumors. They are targeted drug carriers. So that can be liposomes, which we talked about earlier. Self-propelled nanobots, urea-powered movements, silica-based spheres use surface enzymes to react with urine, allowing them to swim through the bladder and overcome natural fluid flow. Here's what nanoparticles activated by light to destroy cancer cells locally. Fascinating. Imagine little tiny robots. Here we go. 2 years ago, bladder tumors reduced by 90% using nanorobots. Nanoparticles endowed with the ability to self-propel through the body are noteworthy. A team successfully reduced the size of bladder tumors in mice by 90% through a single dose of urea-powered nanorobots. Boy, somebody get stock in that company. It's a fantastic voyage. It's like that movie. There was this movie years ago, I think back in the 70s, called The Fantastic Voyage. It had, who was that guy? There was a ride at Disneyland that was for the Fantastic Voyage where you get on a ship and then your ship is shrunk and then you go travel through the bloodstream. Good night, Ulrike. And I'm so sorry about what happened yesterday. Sending lots of hugs to Germany. I should have said that early, honey. Please accept my condolences for your terrorist attack yesterday. Eddie says, what's my opinion of red light therapy for IC? Let's look what the research says, because let's see what the research says. There isn't any research showing that it's helpful for IC, hun. I don't know how it would be helpful. It's a safe, non-invasive treatment that uses low-level wavelengths of light to boost cellular energy, reduce inflammation, and promote tissue repair. The question is, how do they get it inside the bladder to work on the cells in the bladder? Looks like they can do it in the vagina. I don't know. I haven't worked with anybody who's done it. Transvaginal photobiomodulation. Holy man, is that a mouthful. Transvaginal photobiomodulation. Okay, so look, here is... Okay, this is an article on their website from May 20th. The bladder is an organ that temporarily stores urine. Okay, hold on. No, I don't want a mystery discount. It says it can penetrate the skin and reach deep into cells without causing harm like toxic ultraviolet rays. It activates mitochondria, the power-producing organelles within your cells, and helping cells heal and regenerate more effectively. You know, they're not given a lot of scientific research on red light treatment for the bladder indicates that it improves bladder health by stimulating cellular regeneration and improving blood flow. Several studies have shown it to reduce inflammation. All right, so let's go to these studies. They don't make it easy. Terrible website with no links to the research without making you dig. I don't know, hun. I just have no knowledge of this at all. Okay, Sarah, you're confused about phenotypes? What are you confused about? There are different patient groups. We're not all the same. So Hunner's lesion, bladder wall driven from chemical injury, bladder wall driven from estrogen atrophy. There might be more bladder wall driven from allergies, bladder wall driven from autoimmune disease, pelvic floor dysfunction, and widespread pain. Those are the key ones. Lisa, I don't know who Dylan is. Who is that? Tessa says, thank you for continuing to advocate for all of us. I think it's incredibly important that you share the new IC guidelines. My biggest frustration is that despite living in Chicago and seeing specialists at major hospitals for over 15 years, I never had a physician who actually followed the guidelines. So true. My own urologist had never even heard of the phenotypes. So true. I've tried virtually everything: amitriptyline, bladder installations, Botox, pelvic floor, meditation, InterStim, with no lasting success. Eventually, my case was considered too complex. I ultimately returned to Brazil because I could no longer work due to my condition. While the technology here may not be as advanced, I found something I desperately needed: compassionate, human-centered care. Ironically, some doctors here are surprised that I came from the US for treatment, but after years of suffering, I was looking for physicians who would truly listen. Despite receiving care from excellent doctors in the US, I became dependent on opioids because of my pain. Thankfully, I'm now going through detox. What also shocked me is learning that many other conditions should be ruled out before confirming an IC diagnosis, something that was never done in my case after more than 15 years. I still don't have answers, but I've learned so much from you and from everyone in this community. Thank you for giving patients hope and for continuing to push this forward. Honey, may I please use that? I would like to share this in my magazine to other patients because that would be the foundation for my editorial, to be quite honest. So, here's the issue. And these guidelines are truly exceptional. I mean, like the best doctors in the world come together to make these guidelines, patient advocates, you name it, they're there. And like I was on the male pelvic pain guidelines committee for American Urology Association the last couple of years. And I'm telling you, committed, best people you could have, working really, really hard to make sure that we've got a protocol that will help patients that are in pain. And I said to them at the end, after we were done and they were published, I said, all right, how are we going to get urologists to read them? And they all kind of chuckled, and it's like, well, that is the problem. And I said, Well, let's do videos. Let's do something that we can do to entice these doctors to actually read these excellent guidelines. And, they kind of weren't interested in doing that. And then one of them just said, yeah, really, the only people who read the guidelines are patients like you and residents going through training. It's like, ah, it's so frustrating. It's so frustrating that we spend all this time creating a helpful, effective document. And like you said, we can't get the doctors to read them. Number one, they're really busy. Number two, they don't go to the conference. If they go to a conference, they're going to deal with life-threatening things. They're not going to deal with chronic things, Oh, thank you, Thaisa. Let me just, I already copied it and put it in my folder, hoping you would say yes. Let me, I normally don't use names to protect people's privacy, so I usually use initials. So I will do TD, if you don't mind. Man, I can write. Hey, you just gave me my editorial, which is the last thing I write. Thank you. Thank you. This is perfect. I will put this in its entirety. You nailed it. And you're a wonderful writer, honey. A wonderful writer. Okay, so Arlene's asking about homeopathic cantharis. Okay, I know where that is. Hold on. Oh, my foot's asleep. Okay. Whoops. There was a lady years ago. Her name was Diana Brady. Diana Brady was like the leading expert on alternatives for IC 20 years ago. She has since passed away. She wrote this book in 2009. And she was the first to just really try to help patients understand what their options were. I mean, that there were some things that could help. So unfortunately, it's not searchable. I wonder, page 101. I got notes everywhere. I mean, I read the whole thing a couple of times. As a pharmacologist, I'm not committed to traditional medicine. I mean, patients are suffering. We just need lots of options. Okay, so treating. Let me just see if I can find any mention of it in here. Okay, here we go. And unfortunately, she didn't know about any of the new supplements, so like PEA. So it's very old, outdated information. But is there any mention of cantharis here? And there is not. Okay. So let me look in one more spot. So Cantharis is a homeopathic remedy made from the blister beetle. Traditionally used to treat burning and cutting pain during urination. Frequent urge. The blister beetle? I'm skeptical. These are homeopathic uses based on traditional practices from the 1700s and are not evaluated or proven effective by modern medical standards. It is not a UTI. Yeah, and of course, it is not approved by the FDA. I'm going to take a hard pass on blister beetle. Linda said, I went to a urogynecologist a few years back. All he had was lidocaine and chills. He also prescribed some pill that induces a spontaneous abortion. I'm 65. Even my pharmacist questioned why he prescribed it. Within 2 days, my gums were bleeding terribly and I have good health. I quit the med and started the lactoferrin. Linda, what was the name of the med? And Eddie says, how could a male do red light therapy? I have no idea, honey. I have no expertise in that. Again, it's about phenotyping. We need to know what your phenotype is to find the right treatment for your unique case. I don't know. Hold on. Do we know the medication? What medication was it? Was it misoprostol? All right. I think that's probably what it was. Okay, so hold on. There was one study in 1998. Oral prostaglandin misoprostol. Yeah, but there's no research since then. Hi, Kira. Hey, it's nice to meet you. Excuse the casualness. Listen, I'm very casual on Sundays because it's Sunday. And I work 6 days a week. So this is a work day for me. But it's also a weekend for me. So anyway, I just try to do a very casual work day. I think it's crazy that they gave that to you, Linda. I mean, yeah, exactly. I started the day with a walk around the lake. So, I mean, like literally he gave you misoprostol before he gave you any other treatments? Boy, I'd sure love to hear the rationale for that. I mean, because there's just not mentioned in the AUA guidelines as a treatment for IC. I've never seen it in any guideline as a treatment for IC. Now, there's a chance I could have missed it, but it's certainly possible. I find it absolutely baffling. I mean, at the age of 65, okay, if your symptoms started in your cure, of course you can. Go for it. At the age of 65, if symptoms are new, we're always going to look for estrogen atrophy. That your bladder needs estrogen to make that nice thick coating of mucus that normally protect the bladder wall. And what happens as we get older is our estrogen levels drop. Therefore, the bladder doesn't have enough estrogen to make mucus, which means the bladder wall starts to atrophy, which means your bladder's ability to defend itself is now compromised. That's that 1 cup of coffee you used to have every day in your 40s you can't have in your 50s and 60s because your bladder just doesn't have enough mucus to defend itself from the acid. So why they would give you misoprostol instead of estrogen if your estrogen atrophy is weird, I don't know, honey. I just don't know. Okay. He said IC was very hard to treat and offered me that weird pill. I've had IC for 30 years. He admitted he had no ideas. Okay, girl, phenotyping is created for you. Now, listen, you've had IC for 30 years. You've done bladder treatments for 30 years and you never got better, right? So if you didn't get better on bladder treatments, maybe it's not your bladder. So it sounds like you were in your 30s when you got IC, maybe your 20s when you got IC. And so we look at 2 separate things. The very first thing we consider in younger patients is injury. Injury, that usually it's pelvic floor driven. There's a trauma of some type. The other thing we look for is widespread pain. Hey, you know what? It's been 3.5, it's almost 4 hours. I need to go use the bathroom. Everybody, time for a bathroom break. Meet you back in a minute. All righty then. Ugh. Man, time has just flown by today. Wow. Kira says, 2 years ago, I suffered a blow to my pelvis. Immediately, I had severe pelvic pain and urinary symptoms. I also lost my period at that time, and it hasn't returned. Can IC be caused by trauma? Absolutely. My nervous system is not in good health at all, and my urologist said I should start therapy, which I'm going to do. I've been prescribed mirabegron, but it hasn't helped yet. Tomorrow, I'm seeing the pelvic floor specialist. Not sure what else I can do. I don't really have fizzy drinks. I'm 21 years old. I'm really struggling. Okay, girl, I have got your back here. I totally got your back here because guess what? My symptoms started when I was 13 after a pelvic trauma. Okay, I actually fell and broke my tailbone into 2 pieces. So, physical, the bladder, like any other part of the body, can be injured. Generally, it's injured through chemical exposures, but the bladder can be injured through physical exposures. Physical trauma. There was a very interesting case a couple of years ago of I don't remember if it was a guy or a girl, but they were playing soccer and they got hit in the bladder, the lower abdomen, with the soccer ball, and it ruptured their bladder. Their bladder literally just broke. And that is particularly true if your bladder is full and you use you're using walking sticks. Now, were you using walking sticks before you had this trauma? So anytime symptoms start in teens and 20s, we always probe for injury and trauma first. So kind of concept number 1 here is that your bladder itself could have been traumatized, but I'm really, really glad you're going to the pelvic floor specialist tomorrow. Okay, girl. She said she did not have any pelvic pain or use a wheelchair or walking sticks. Listen, the bladder doesn't cause you to need a wheelchair. The bladder doesn't cause you to need walking sticks. A pelvic floor injury would. So anytime somebody has issues with mobility, we stop looking at the bladder and we start looking at the other structures near the bladder, like the pelvic floor. So I would bet that when you go to the physical therapist tomorrow, they are going to find a massive pelvic floor problem. And so let's talk about this appointment. Okay, so and hopefully they're certified in pelvic floor. Okay, listen, if they tell you to do Kegels and they don't do an internal exam, then they don't have the right training for your case. Okay, this is an internal assessment. So when you go to the physical therapist, you're just going to wear workout clothes, right? No biggie. Be super relaxed. Normally, what they're going to do is they're going to have you walk down a hallway. We want to see how you're walking. And clearly, if you're using walking sticks, there is a problem with your gait. They need to understand why. Is it a SI joint? Is it a tailbone? Is it a hip? They will normally measure your legs. You have one leg longer than the other. And your ability to describe your symptoms gives them a roadmap on where to look. So I really want you to tonight, and even now, you need to start writing down your symptoms, and not just your bladder symptoms. I need you to write down what is happening to tell you you need to use a walking stick? Like, do you have any pain that goes down your leg? Do you have pins and needles, areas of numbness, a vibration, anything funky going on? And the same with the wheelchair. What is it that's telling you you can't walk, you need a wheelchair? Okay. You're going to be a really interesting case for them. And I don't want you also have piriformis syndrome. Well, okay, there you go. Piriformis syndrome is pelvic floor dysfunction. I have piriformis syndrome too on my left side. Piriformis syndrome means that your pelvic floor muscle is so tight that it causes burning and tingling because it's squeezing a nerve. Mine is buzzing right now. I have almost every day a low-grade vibration in my piriformis muscle on my left side. That is an old traumatic nerve injury that I have. Okay, so we know you have pelvic floor dysfunction. You just confirmed it. You've been diagnosed with it. So what that physical therapist really needs to do is just try to understand your body mechanics more. There's clearly something restricting normal muscle function that's allowing you to walk normally. And that's not the bladder. It is impossible for the bladder to physically change how you walk. Muscles and nerves do that. So they're going to ask to do an internal exam. Please let them do that. That's the most important part because you can only touch these muscles internally. Now, a healthy muscle feels like a raw chicken breast. It's soft, but it has substance. A tight muscle feels like a rubber overcooked chicken breast. There's just not a lot of give to it. And then a badly damaged muscle feels like beef jerky. There's no give to it. So what she's going to do is have you lay on a table. And I want you to go into this with a sense of curiosity and adventure. Girl, you're 21. We want to fix this. You know, and this is not something that you should put off. I mean, you want to learn as much as you can about the pelvis and the muscle. I've got a great book that will do that. But in the same time, let's get a new set of eyes studying your pelvic anatomy and how you're moving your body, because there is a problem there. So you're going to lay on a table. Your knees are going to be up. You're not in stirrups. It's super, super easy. They will have glove. They will have KY. They will insert their finger into your vagina very, very shallowly. All they're going to do is touch muscle groups, left side, right side. If they can touch a muscle and trigger this pain that you're having, that is what I call your hallelujah moment. It's like, oh my God, that's it. What are you touching? We need to know what that is. Your goal is to walk out of that appointment knowing that your levator is tight or your obturator is tight. And clearly we also know your piriformis is tight. And then where? Left side, right side. The other challenge here is that you're having tingling. You're having neurological symptoms, which means that we're dealing with nerves. So when you sustain a big injury like that, you suffer what we call a compression injury. Whether you were hit, whether you fell, it's not just your bladder. If you fell, all your weight landed on muscles and nerves and blood vessels. If you had a bruise, that proves that it was such a violent interaction or trauma that the blood vessels were broken, and that's why you bruised. So physical trauma begets a wide range of effects. We might have damaged muscle, we might have trigger points, we might have damaged blood vessels, and we might have damaged nerves. And if she finds trigger points, we're going to want to treat the trigger points because those are just little hard muscles that are stuck that need to be relaxed. A trigger point, muscle fibers work like this. You have a muscle fibers go the length of the muscle, and when they're relaxed or released, they're basically at tip point. And then when they get tight, the muscle fibers slide together. So like this, those are muscle fibers that slide together. And then when you relax, oh, sorry, my microphone's in the way. I don't know. I have bigger muscles on my right side than my left side. Okay. So when you're using the muscle and you need strength, the muscle fibers slide together like this. And then they're supposed to release, right? They're supposed to release and go back to this. But sometimes they don't release, and this becomes a muscle knot. It's a trigger point. And, you know, we've all had them in our back. And usually when you have a trigger point, you find somebody to push on it. Because when you push on it and rub it, you can get the muscles to release. So they're going to be looking for trigger points that they can release. It is reasonable, given the fact that you are needing to use a wheelchair. I hope you've had some imaging done. CAT scan, MRI. We need to know a little bit more about any skeletal, bony structure injuries that might have happened. And the goal here is when they identify the injury, they can really work to heal that injury correctly, because you doing bladder therapies bladder therapies aren't going to touch piriformis syndrome. Physical therapy heals piriformis syndrome. So let's not get lost in IC bladder treatments. You know exactly when your symptoms began. They began after an injury. So the question now is, what's the injury? And I don't think you really know. So you know what I would really love for you to do is, after you go to the pelvic floor specialist tomorrow, call me. I want to hear what they find. And in the meantime, so if my guess is right, which I'm sure it's playing a role because you already have the diagnosis. The reason why your bladder gets diet sensitive is because your muscles are so tight, they're squeezing blood vessels, and your bladder just doesn't have good blood supply. It's called ischemia. So if your bladder is supposed to get 23 units of blood a day or 24, and it's only getting 10 because your muscles are so tight, is your bladder wall going to be healthy? And the answer, of course, is no, because it doesn't have enough nutrition. But as you do physical therapy, the goal of physical therapy is to restore blood supply to the nerves and to the other tissues. Okay, you had an MRI in January. It was clear. You also had a hip x-ray. You have bad hips, which found compressed nerve and bone growth. Okay, that's huge. Oh, Kira, you're welcome, honey. Anytime. Listen, anytime at all. If you have questions, please don't hesitate to give me a phone call. I am more than happy to try to help you, honey. Here's my phone number. This is the IC Network phone number. It's toll free. Feel free to call. I'd love to hear from you. And I just really want you to know that you're not alone in this. We've got some pretty big clues. And so your physical therapy appointment, make sure you bring them the results of the hip x-ray. And that's like huge. And honestly, the shoes that you wear are probably going to be really important. And so make sure that you're not, I mean, you need, like Hoka's, this is not the time to be wearing flip-flops, and it's not the time to be wearing Skechers sneakers. You need a shoe that will help your foot hit the ground correctly so that it doesn't put more stress on your hips, and etc. And these are not I'm not talking granny ugly shoes at all. You got a major injury. And so the shoes that you want something like a Hoka shoe. Hokas are pretty expensive there. But here, I mean, I am a piriformis syndrome patient. I only wear Hokas when I'm walking, or I wear Nike slip-ons, which I'm wearing right now. And that's something that the physical therapist can potentially guide you on too. Okay, wait a second. Did I just lose my... Hold on. Okay, I just closed my window. I got to find my window again. Hold on. Wait, where did I do with it? Oh, here it is. No. Oh, wait, hold on. There's YouTube. What happened to my... Oh, here it is. Oh, Facebook closed on its own. Dang. Well, it is 4 hours. All right. Well, Facebook shut itself down. I think it did. Hold on. Wait a second. Or did it not? Wait. Okay, it's not on that window. It's not on this window. This is what happens when I accidentally close windows when I'm live streaming. Okay, hold on. Let me just see if okay, it's not there. I think we have... Okay, it's not there. 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 Oh, wait. I found it. Oh, sorry about that. One of my daily goals is I have so many windows open, things get lost, and every morning I have to go in and delete. I have to set up my computer by getting rid of all these open windows. So anyway, okay, so we are fixed. Kira said you have you got some of the shoes? Good. Good. All right, guys. So listen, we've got 5 there and 15 here. So it's been 4 hours and 15 minutes. Yeah, baby. But my voice is starting to give out. So let me do a last call for questions. I may take a couple of weeks off in August. Am I able? Kira says, can I pop you a message tomorrow? Yeah. You're in the UK? Sure. Here, email me. Here's my email. And I can do Zoom. I'm in California, hun. So, you're a good 8 hours ahead of me. So sure, pop me an email. All right, guys. Last call for questions. All right. I'm going to say goodbye to YouTube. I'll see you guys next week. Knock on wood. Fire season. Wish me luck.